Hi, Shona. Good evening.
Hello, Kostabda. Good
Ah,
evening.
okay.
Hello, good evening.
Good evening, sir.
Gustav, we're live now.
Okay. Okay. Good evening, sir. Good evening, Dr. Cesar. Sir, can you hear us?
Yes. Yeah.
Okay. Okay. Thank you.
Good evening, everyone. I hope I'm audible.
Yes, you're audible.
Yes, sir. Yes, sir.
So, good evening. I welcome all of you once again to the second class of the head and neck module of the AROI West Bengal chapter course on 2D and 3D planning. As we have already seen in the first class, there has been tremendous enthusiasm and a lot of participants have been joining in all across India, as well as a few from Bangladesh. And we also know that there was a lot of interaction in the previous class. We have got feedback that this is the part that most of you loved. And we hope that we can actually have more interaction in this particular class and going forward. And for that reason, we would want to start right on time, so we would not waste any time in going forward. You already know the scheme of things. So you would first have a session on radiological anatomy where the radiologist, Dr. Shaunak Paul, will actually interact with Dr. Kaustubh Majumdar and talk about the radiological aspects which are assigned for today. Then we have two back-to-back talks, of course, one by none other than Professor Cesar Kainikal, and we are very thankful that he is being able to join us. So he'll be talking on the 2D aspect today, and this will be followed by another talk by my very dear friend, Dr. Trinanjan Basu, who would be talking about the 3D aspect, and we would have live question answer session throughout. So without further ado, can I request Dr. Sezal to give his introductory comments so that we can start with the first session on radiological anatomy, because he is the expert. And I also see that Dr. Chandan Dasgupta has joined. So after Dr. Sezal, if we can have a few comments from him as well, and then we can take this forward. Thank you so much.
Sir, you are not audible.
Dr. Sezal, I think you need to check your microphone once. You are not audible.
Okay, can you hear me now?
Yes, absolutely. Please go ahead.
Okay. Yeah, I think there is some problem. Okay, I sincerely thank the AROI, the West Bengal chapter for this great initiative, because it's a bridge between the 2D and the IMRT planning, and this is a bridge between the old generation and new generation, and the youngsters will know how the radiotherapy of these different sites planning has evolved over the years. And we know that the radiology is an integral part in head and neck radiotherapy planning. So first we will have this session on head and neck radiology of the nasopharynx and the parotid. Then we will go for the 2D planning. And I hand over the mic to my coach or co-expert for to start the proceedings. Thank you.
Chandan sir, are you there? Hello? Chandan sir? Hello?
Can you hear me? Can you hear me now?
Yes, sir.
Oh, yes. Good evening and welcome everyone to this AROI West Bengal Institute of Controlling and Radiotherapy Planning classes. This is the back-to-back second class of this module 1 on head and neck cancer. And as it has been already discussed and told by Abhishek and Dr. Sehgal that we are going to discuss on the nasopharynx and salivary gland malignancies this evening. And let me invite Shaunak Paul and Kaustubh Majumdar.
Some technical glitches. Am I audible?
Yes, yes.
Okay. So I will start today's radiology class. So first we have going to start the nasopharynx and then followed by parotid, and from the yesterday leftover the sinuses. If we time permit, then we will continue to that also. So first I would like to request Dr. Shaunak Pal to show us the nasopharyngeal boundaries, preferably in, if it is possible, in the, coronal section, the boundaries.
Good evening, Dr. Kostov, and thank you, AROI team, for inviting me again for this. So we'll jump right into the sessions, and we will start. You wanted in coronal, Dr. Kostov, or shall we start with axial and then go back
Okay,
to
okay,
coronal?
fine. Okay, go
I
ahead.
think it will be easier for everybody to understand if we start with axials, and then we can do that. So this is the nasal cavity here on either side. So the posterior most aspect is the posterior choana. So this is the anterior margin of the nasopharynx. And this is the clivus, this bone here. So this is the posterior margin of the nasopharynx. And the soft tissue structure you can see are on either side are the walls of the nasopharynx. So when we discuss the nasopharynx, the first thing that we are interested is in the depressions in these two sides posteriorly. Okay, these are the fossae of Rosenmuller, and the depressions on either anteriorly, these are the eustachian tubes. So wherever the commonest site of a malignancy is from the fossa of Rosenmuller, so you will usually have an asymmetric growth on either side, which may or may not extend across the midline to the other side. And in these cases, the the torus tuberous, the soft tissue bump here, it gets displaced anteriorly, so much so that the eustachian tube is blocked, and you often see the mastoid air cells are opacified on that particular site. So when you are seeing a mastoiditis, please always look out for this. And then coming to your request, Dr. Costa, we will go to the coronal images. So we can see a smiley here, and this is the eustachian tube on either side, and just superior to this part is the fossa of Rosenmuller. And here is where you have to look out for the malignancies in nasopharynx, these depressions on either side. Okay, next question,
Okay,
please.
Next we will move to the, normally what happens, nasopharynx is,
Dr.
extending to
Kostov, can
the-
you be a bit more loud? I
sorry,
cannot.
sorry, and now audible? Now
Yeah,
is it fine?
better.
Okay, so the nasopharyngeal tumor normally goes to the, the intracranial extension occur, it's going to the superiorly. So in the base of the skull, there is various foraminas and sinuses are there, through which there is an invasion occurred. So I'd like to ask Dr. Shonappa to show us few structures. Should we start with a sphenoid sinus?
Yes. Shall I go back to the axial? Is it comfortable for you?
Sure, axial.
Okay, give me a second. So this is our sphenoid bone here. This is a sphenoid bone here, and the air space between this is a sphenoid sinus. And as per your prior request, this is the sphenoid sinus. Okay, this entire thing here, which may or may not have a septum to divide it on the right and left divisions. Okay, next, Dr. Costa.
Now we'll move to the various foramina, that is from our MBBS first year. So we'll start with foramen lacerum, and we'll then move to foramen ovale. Now, first the foramen lacerum, please.
Okay.
And please tell us
I will
also how to identify the foramen lacerum.
Yes, definitely. I will change it to a bone window setting, and so can you appreciate two oval structures here? One here and one here. The posterior one is the foramen lacerum. The anterior one is the foramen ovale. Okay. So it is along the base of the greater sphenoid, greater vein of the sphenoid. And the foramen ovale is entirely within the greater wing, whereas the foramen lacerum is between the greater wing and the mastoid process. Next question, Dr. Costa.
So next is the foramen.
Do you want to have a look at the coronal of this? I think that might help you.
Okay, okay, that's fine. I mean, we have to control mainly in the axial section. So
Oh, then
it will be better.
we'll skip that part.
So okay, then we move to foramen rotundum.
Okay, for foramen rotundum, I think it is always better to go for a coronal section when you are hunting for the foramen. Okay, it helps a lot. However, on axial, this lane, this bony enclosed lane is the foramen rotundum. We will just diverge a bit into the coronal plane. Okay, when we have the sphenoid sinus here, I think the pointer is visible.
Yeah.
At the foramen here is the Vidian canal, the canal for the Vidian nerve. It is inferomedially, and another foramen is here. This is the foramen rotundum. Okay, this goes anteriorly into the middle cranial fossa. Next, please.
And then we cleavas you have already mentioned in this posterior boundary. Next,
Sorry.
Cleavas you have already
Clivus,
mentioned.
yeah.
So next is to the cavernous sinus.
Okay, this is the clivus once again on a sagittal plane. I'll come back to the cavernous sinus now. Okay, give me a second, doc. The body of the sphenoid. Okay, we are going just a bit down, and you can see a hyperdense structure on either side. Okay, this is the level of the cavernous sinus through which the cavernous segment of the internal carotid artery passes. So these calcifications on either side of the body of the sphenoid or in the suprasellar region are the calcifications along the cavernous segment of the internal carotid arteries. And whatever enhancement you see on either this is a late study. You can appreciate it because of the enhancement in the transverse sinus. So similar enhancement is there in the cavernous sinus. Okay.
So here in this cavernous sinus, what would be the upper and the lower boundary of it? I mean, upper cut and lower cut. Is it anything defined here?
Sir, it is not exactly defined. However, up to the level of the dorsum sella, you can see the level of the cavernous sinus, and inferiorly it is posteriorly marked by the Meckel's cave, and laterally and the greater wing of sphenoid, and medially it's the body of the sphenoid.
And the lower any boundary?
Pardon me, sorry.
And the inferior part.
Inferiorly, it is just fuses. I'll go to the coronal. It will be easier to explain. Give me a sec. So this is the body of the sphenoid, and the entire zone here. This is the area of the cavernous sinus.
Okay, fine.
Okay.
Thank you. And next is our petrous part of the temporal bone.
Okay. So we'll go back to the bone window again. Sure. And this, what you see is this plate is the squamosa of the temporal bone. And this triangular structure here on either side is the petrous part of the temporal bone, which lodges the otic capsule, middle ear, and the mastoid ear cells.
I'm just intervening for one brief second, Dr. Kaustav and Dr. Shonak. Am I audible?
Yes, sir. Yes, sir.
So there is a question which I think is relevant to what we are discussing from one participant, and that is there any particular window for head and neck structures during contouring that helps us to correctly delineate the structures with minimal chance of geographic miss? So can I just add one thing to this? So the importance of the appropriate window setting for both the target as well as for contouring of certain OARs. Like one question has just come in from Dr. Nikhila, how to identify the cochlea. This is also important in the bone window. So can you just elaborate that? And also for someone who has probably not done the previous class, the importance of the correct amount and the duration of the contrast and when we should take the contrast enhanced scan. So can you just go to
Sure.
these points as you move?
Sure,
Thank you
sir.
so much.
So first we'll come to the first question about the windowing. So I think I have switched off the annotations. I'll just toggle it on for a second. Here we can see the window level and the window width. Okay, I'll toggle it off because the names are there. And this is a recorded session. And so what we have as a window level is the set middle part of the enhancement or HU value that we consider. I mean, suppose we are taking at a window level of 100. So anything that has a HU of 100 will be at the center of the spread of gray attenuations that we see throughout the screen. And when we have window width, when we talk about window width, it is the span of HUs that will be included above and below it. So suppose we have a window level of 250 or 50 or 60 at a soft tissue window, and the window width will be 250 or 350. So we can go on either sides as your distribution of the grayscale. It is difficult for me to explain. I don't know. This is the window level, and this span is the window width. So this is the baseline HU that we consider, and the width of the HU on either sides. So anything that is brighter than this will become white, pure white. Anything that is lesser than this will become black. Okay, so this is, as you have correctly mentioned, now we have a window which is very similar to a bone window. For bone windows, we have an HU level of 800 to 1000 and window width of 2000 to 3000. Okay, so that is the span of attenuation that we check. So anything that is having a HU of 800 will be at the center of this imaging, and we will not miss out the details of the bone. However, when we go back to an abdomen window or a brain window, then the entire thing changes. It is roughly around 30, 40, up to 50 at the window level, and the window width will be around 350. So whatever is above 350 from the window level, it will all become white. So we cannot delineate the bones properly. Okay, the bones are at a higher attenuation than that of the rest of the soft tissue. So when we want to assess the foramen and everything, we change the window settings to the bone window. And as sir asked, the cochlea. So at the medial part of the Peters process of the temporal bone is the bony OT capsule. So this entire hyper attenuating or sclerosed looking structure is the inner ear, and within the inner ear, do you want me to zoom this up?
Yes, please, because this is very important for contouring as an OAR.
Yes, sir. So I will concentrate on one side. It will be easy to explain. In the inner ear, we have this round structures. It is like a smaller disc on a larger disc. So this is our cochlea, and from there we have a communication into the vestibule, and from vestibules we have the semicircular canals. So this is the lateral semicircular canal, and this is the posterior semicircular canal here. And as we go higher up, which almost at the level of the rest of the brain parenchyma, we can see the superior semicircular canal, which is going anteriorly and posteriorly, going down up to the level of the vestibule. And also we have, this is the internal auditory meatus where the cranial nerves are there, and if you have a schwannoma, this will be the location for the schwannoma. I think I have answered your question, sir.
Absolutely, absolutely, Sonak. One thing I have to mention here to the, to the participants, that when you are contouring the cochlea, we have to include the cochlear portion and the internal auditory meatus, whatever Dr. Sonak has been told, and also this vestibule. So all these things is taken into account where you are going to contour these things. This is the important for the contouring. And regarding one comment regarding all these, width and which part of this CT scan, I would like to mention, when you are going to search any kind of foramen, go for a bone window which has in the maximum contouring softwares, there is a one bone window options, and you can change the window and levels there also. So when you can see the bones properly there, contour on identify the bony structure from there only. The rest you have to identify from the abdomen or the soft tissue structure, whatever present in your contouring software. I think that's
Gustav.
Yeah.
Can I make a small comment? Hello.
Sure.
Yes, sir.
Yeah.
Yes, sir. Please.
So regarding cochlea, one thing is that usually we take for planning scan, we take a 3 mm scan. So we can't see cochlea we can see cochlea mostly in 2 cuts maximum. Then because we are taking 3 mm cuts. And one recommendation was there for contouring cochlea. After contouring the cochlea itself, then to give a 5 mm margin surrounding it, because the volume in a 3 mm cut becomes so small that it is very difficult to calculate the actual dose it is receiving from the during the planning time. So the recommendation was to give a 5 mm margin over the actual cochlea, so that you actually get a representative dose which is going into the cochlea. So we follow that regularly.
Okay, thank you.
So,
Thank you.
Kostav, quick comment from my side also. So I think Jivak has raised a very important issue, which possibly Dr. Sejal and Trinanjan will also point out. So when we are taking planning scans, it is very important, especially for head and neck and brain, to look at the slice thickness. If you take very high slice thickness above 3 mm, then certainly, and this is also important for nasopharynx, which we are now discussing. So it is recommended that it should be 3 mm or sub 3 mm. In some situations, we would recommend maybe 2 mm or 1 mm slices when we do this. This is very, very important for residents to note, that you cannot have the same slice thickness that you are using for head and neck and brain for other sites like the thorax and pelvis. So this is very important. And the other point that Kostav just pointed out, I think you have presets. So the term that he was looking at is presets in terms of the bone, the different window width and window levels. So this is important, but it is also important to note the actual window width and levels, which Dr. Shaunak has so nicely pointed out. But as starters, you can have presets and you can toggle with them when you are doing, but it is important to do it in the proper window. Thank you.
Okay, thank you, Dr. Vasu.
Thank you, sir.
And I think now I'm quickly going to the few fossa and foramens, which is important for the nasopharynx. That is, you have already mentioned the last class. So could you please just show the few things very quickly? The pterygoid fossa, ITF, pterygomaxillary fissure, and after that the retrostyloid space. These are important for our contouring purpose. So just quick.
I think I will jump across this first question of the
pterygoid fossa.
Sorry. Yeah, pterygomaxillary fossa fissure, and the entire thing. So we have discussed this in the earlier class. This is the greater palatine nerve or the foramen, and on the posterior aspect is the lesser palatine foramen. So when we go through along this, between the pterygoid and the maxillary is the pterygomaxillary fissure and or pterygomaxillary fossa, and on the lateral aspect is the pterygomaxillary fissure, which connects with this. Sorry, Dr. Kostav. Where is the next?
And
one
next
that
is ITF. That's the infratemporal.
ITF, I think we will go to the coronal for this one. So this is the maxillary sinus. Okay, as we give me a second. This is the maxillary sinus, and as we go posteriorly, this is the posterior margin of the maxillary sinus. From here, the ITF starts up till the level of the carotid sheath. This is the carotid vessel. Okay. So the entire fat plane here, the entire thing is the ITF anteroposteriorly, and lateral determination is from this lateral pterygoid plate to the ramus of the mandible. So this zone is the span on transverse axis, and superiorly we have the greater wing of the sphenoid, which we can see the, which one is this? This is the foramen ovale, and inferiorly we have the medial pterygoid muscle. This is the lateral pterygoid plate. This is the medial pterygoid plate. The muscle in between is the medial pterygoid muscle. So this forms the floor of the ITF, but it is not a complete floor that is formed, because this is not present as we go anteriorly, and anteriorly this fat plane is in communication with the fat plane along the lateral margin of the maxillary sinus as well as the buccal fat plane.
Can
Okay.
you show us please in the axial place?
Yes, this entire thing. Now
I mean,
that
only the ITF, I guess.
only the ITF, yeah. So this is your medial pterygoid muscle. So anything above this level here, excuse me, this entire area, sorry, not the entire one, I mean anterior to the level of the carotid. This is the carotid sheath. So anterior to this level, this part, sorry, this part is the ITF, and laterally again the ramus, medially the lateral pterygoid plate, anteriorly the posterior margin of the maxillary sinus. Am I clear?
Yeah, absolutely. And thank you. And next is the retrostyloid space, the styloid process and the retrostyloid.
Yeah. So this is the styloid process here. This is the styloid process on this side. And as we scroll up, we can see some amount of fat plane here along the posterior margin of the styloid. So whatever anterior, this fat is the anterior or the pre-styloid parapharyngeal fat. This is our pharynx. This is the component of the nasopharynx. And when we scroll down, this is the component of the oropharynx. So whatever fat is here anterior to the level of the styloid, this is the pre-styloid parapharyngeal fat. And the post-styloid region, the carotid sheath is included in the post-styloid region. And when we go further higher up, we can see some amount of fat here, and we can see a foramen here. Okay. Again, when we come to foramens, we again change the window to bone window so that it's easier for us to trace. Otherwise, because of the artifacts, it will be difficult to identify. As again, then we go higher up, this round structure, this is the vertical segment of the foramen, facial nerve. And are you tracing it along with me, or
yes, absolutely. So I am going to the next.
I'll zoom it up a bit again.
I'll go into your next thing also. I mean, after showing the retrostyloid, I will tell you to show the facial nerve up to the stylomastate foramen. If you can improve.
Okay, so we usually start tracing the facial nerve on a reverse way. It is easier for us to find out the stylomastoid foramen. You check the styloid process, you go higher up, you see the foramen. This is the stylomastoid foramen. Then you trace it higher. So this is the vertical segment. And then after a point of time, when we have this level of the cochlea and all the inner ear structures, then you can see the foramen here. It changes course and it becomes transverse. I think it is appreciable, Dr. Costa, this transverse segment. So this is the level of the genu, where from the vertical segment becomes a horizontal segment, and this is the transverse segment of the foramen. And we have something of a connection between the Meckel's cave and the facial nerve by a small nerve, and this area is the Meckel's cave. So from here, there is another bony canal that connects all the way up to the facial nerve. So this may cause tumors that have a predominant distribution along the facial nerve to have pain as that of a trigeminal nerve. So clinically, it will be a patient may present as a trigeminal neuralgia. It will be from 1/7 to 5th nerve transfer of tumor along the distribution of these nerves. Next question, please.
Okay. I mean, now I will move to the parotid. I mean, our salivary gland. I think the nasopharynx has been completed. I have told Dr. Shonak to show the structure in some topsy-turvy manner, but still this structure, when you are going to read the contouring guidelines, everything, when you will see the structure, you will find this structure very much important. Whichever we have discussed for last 20 minutes, these are important for the contouring things. So next is the parotid. So in the parotid,
Dr. Costa, I'm just interfering once. So there is one open question which, before we move to the parotid, is in the same region. So can Dr. Shonak please show us the region of the retropharyngeal lymph nodes? So the region where you would actually look for the medial and the lateral retropharyngeal nodes. So that is the question. And just a note before you move on, that is the class that we are having is a little bit different from the classes on contouring. So here we are not actually showing you contouring because contouring guidelines are freely available all through the net and all of you have access to that. What we are trying to show, and we are thankful to Dr. Shonak for this, is to have the radiologist and show you the radiological anatomy instead, because once you are comfortable with the radiological anatomy, I think interpreting the contouring guidelines should be very easy. So that is the motto of the series that we are having. So Dr. Shonak, can you just tell us about the retropharyngeal and then move to the parotid?
Okay.
Thank you so much, sir. Thank you so much.
Dr. Shonak, just for our purpose, we will complete this retropharyngeal lymph node. So just for our contouring purpose, you have to show few structures. For example, the superior inferior is the base of the skull. Or in the inferior transverse process of the C1 vertebra, that is the superior. Could you please show that?
Yes, sure. So for the base of the skull, just one moment, I'll digress, Dr. Costa, for the question that sir has asked. So this is, I will take you from higher up. So this is the carotid artery that goes down, and we put a line in the medial margin of the carotid artery. Any lymph node that is on this, in this fat plane, sir, along the medial margin of the carotid, these are the retropharyngeal lymph nodes. This is the level of the pharynx. This is the carotid. So these are our retropharyngeal lymph nodal stations. Occasionally, you might find a few lymph nodes in this, and if they are not attended to in appropriate time, I think we all know there might be a nodal recurrence, which we all don't expect. And next, coming to your question, Dr. Costa, so we start from the higher base of the skull to C1 transverse arch. So again, coming to this level of the carotid, we just go down. So this area is the base of the skull. Okay. This area is just below the base of the skull, sorry. And as we go down, C1 you asked?
Yeah, C1, the transverse process of the C1 vertebra. Yeah, that is
Okay,
the superior
we'll go back to a
boundary.
bone window. When we see a structure like this with a small peg and a ring all around it, this is the odontoid process and this is the C1 arch. This will be your transverse process of the C1 vertebra.
So this is the superior. Now we will going to the, I mean,
This is the inferior. Superiorly, we dealt with already the base of the skull. Yeah.
no, I think, I mean,
Oh, sorry.
mainly the inferior boundary is the cranial edge of the hyoid bone. That is a totally inferior boundary of the retropharyngeal lymph node. So now we are going to the medial boundary. So it is the lateral edge of the longus capitis muscle. Can you please show that?
Longus coli, I believe.
Longus capitis. Longus coli.
Yeah, this I'll change the window back to a more suitable one. This is the longus coli muscle. So this will be your boundary. But we don't usually consider this muscle as the hard and fast marker for retropharyngeal lymph node, because the retropharyngeal lymph nodes may occasionally cross along onto the medial to the medial margin. Okay.
So that is your longus coli muscle.
This is the longus coli on this side, and this is longus coli on the other side. So there is ample amount of fat that extends posterior to the pharynx, and the lymph nodes may sometimes jut out here. Okay, so what we consider is from medial margin of the carotid, anything medial to this is the retropharyngeal.
And absolutely, the lateral margin is the medial of the internal cavity that already you have shown.
Yes, that is.
And the anterior posterior margin is the fossa under the pharyngeal mucosa.
Okay.
And could you please show that?
So it is difficult to appreciate the fascia on a CT.
Okay.
So we will have to go by the walls of the pharynx. Okay, so this the walls of the pharynx will be the limiting structure. I mean, the soft tissue that we can see here, this will be limiting structure. Fascias are not always seen on imaging, and only a couple of them can be seen.
Okay, and the posterior boundary is the prevertebral muscles.
Yes, this is the prevertebral muscle. This structure here. Okay.
Okay. Thank you. Now I will move quickly to a few things of the parotid.
Yes.
I will not go for any kind of further things. But in the parotid, could you please show us the zygomatic arch?
Okay.
Yeah. So in the zygomatic arch, it is the superior boundary of the parotid gland.
Let me zoom it down a bit. So this is the level of the temporomandibular joint here. These structures, these horn-like structures on either side is the zygomatic arch. Okay. So when we go below, so this is the inferior margin of the zygomatic, and this is where you're looking for. Next question, sir.
Okay, and you have just one thing, the inferior boundary you have already showed the styloid process you have already shown.
Yeah, this is a
anterior boundary, the anterior border of the masseter you have already told in the previous class. And next is the posterior is the mastoid process and external auditory canal. Just quickly, the external auditory canal and the mastoid process.
This is the external auditory canal here. There is a question, I believe, or we'll take the questions later, sir.
Oh, later. Yeah.
Yeah, this is the external auditory canal, the bony segment, and as we go below, this is the mastoid. So if we end at the tip of the mastoid here, and by the time we can already see there is a fat-rich structure. This is the parotid, and I hope I can guess your next question: the superficial and the deep lobe of the parotid.
Yeah.
So what we have is the facial vein here, and this is the posterior margin of the ramus of the mandible. We make a line through this, and anything on the lateral aspect of this is a superficial lobe of the parotid, and anything on this side is the deep lobe of parotid. Very minimal tissue is there, this triangular wedge. So this is the deep lobe of parotid. Okay.
Okay, okay. Thank you. So next, I think I have, if we have 5 minutes at least, we will go for a paranasal sinus, mainly in the maxillary sinus. So could you please show us, there is one structure called the on-grains, not structure, this is a imaginary line, the on-grains line, which is divided, it is between the suprastructure and infrastructure of the maxilla. So it is from the angle of the mandible to medial canthus. Could you please just show it?
Sir, it will be difficult to show this on CT. I think it is a clinical line that we take from the inferior angle of the mandible, and I'll still give it a try. So this is the level of the medial canthus here. This is the level of the medial canthus here. So I'll put my mouse, and we will scroll down, and from here to this is the imaginary line. But I think when we are discussing on CT, we should be discussing about the suprastructure and the infrastructure. I think that will give you more clarity, and whether there is a chance of operability, or we need to go for the orbital exenteration or likewise. So I will just take on a new question, sir, without your permission. So we take two lines, we make two lines. One is along the inferior margin of the antrum, and another is along the superior margin of the antrum, not extending into the orbit. So between this area is the infrastructure, and this area is the mesoinfrastructure, and this above this is the supra-infrastructure. So anything above this line, which even can include this space, goes as a supra-infrastructure, and we will need an orbital exenteration in most of the cases. However, whether we go for orbital exenteration is a surgical decision, and it's a on-table decision. If the periosteum is involved in a periosteum, then we need to go in for a exenteration, and if it is not involved, then probably a maxillectomy should be sufficient.
Okay. So my last, it's my last question. One is just show us the nasal cavity and the ethmoid sinus above, and how to differentiate when the nasal cavity going to the ethmoid sinus and the maxillary sinus. Just show that.
Sir, it's easier to understand on coronals, so I'll show it on coronal, and then we'll go by into the axials if you want. So anteriorly, we have this is the these are the anterior nares. When we go posteriorly, this is the inferior turbinate, and this is the middle turbinate. So up till here, we can see there are a lot of bony septations. So this part is the ethmoidal, this is the maxillary, and this is the nasal cavity. And as we go posteriorly, we have the sphenoid, which is in communication with the ethmoidal. And as we go anteriorly, here we have hypoplastic frontal in this patient, not much of frontal sinus is seen. And the communications are very evident. I believe we can see that the bony septae are not completely dividing the ethmoid from the nasal cavity, as well as when we see on the maxillary sinus, we can see there is some amount of space that communicates the maxillary sinus into the middle meatus. Okay, so this area is the osteomeatal complex, and entire thing is connected. So any tumor of one of the sinuses may as well spread via these, because these are paths of least resistance into the nasal cavity or into the adjacent sinuses, or they may infiltrate the bone and go into the orbit or into the infratemporal fossa posterolaterally.
You have already shown us the inferior terminate and the middle terminate. Could you please show us the superior terminate? Is it possible?
Sir, in this one, I don't believe I can show, because no, sir, not in this scan.
Okay, okay.
Not in this scan. It is hypoplastic in this scan. Superior turbinate is not always seen in every patient.
Thank you, Sonak. I think we should wrap up today.
Thank you so much. Thank you so much, Dr.
Thank you,
Kaustav, and
Dr.
thank you,
Sonak. There is a
AROI
very-
team.
Okay, okay, thank you. And we'll move to the next class. Over to Dr. Abhishek, sir. Move forward. Thank you.
Thank you for an excellent discussion. Can we now move to the next talk by Dr. Sejal, please? And I know there are a few questions still remaining, but I request all of you to mail them to the mail ID that has been mentioned, and we will still try to pick them up in the next classes as we move along, because we'll have Dr. Sonak in the next classes as well. Thank you so much. Dr. Sejal, please.
Yeah, I sincerely thank once again for the invitation. So I will build from the radiology discussion. So there will be three components for my talk. One, the outline of the staging and stage-wise management. Number two, to see few of the images, CT and MR images. So how you have to look into that. And third is the outline in the two-dimensional radiotherapy planning. So that's will be my plan for today. I will discuss, I will take 30 minutes for my presentations. Please feel free to interrupt me in between. So if you look into the axial anatomy of the nasopharynx, this is very important to know the extent of the disease. This is the fossa of Rosenmuller. This is a lateral pharyngeal recess. So this is a torus tubaris. And you have the structures which we mentioned. This is the pre-vertebral muscle. This is the longest capitis muscle, and this is the longest colli muscle. So there was a question where to look for the internal retropharyngeal lymph nodes. The retropharyngeal lymph nodes is seen medial to the internal carotid artery. So this is Dr. Paul has clearly mentioned that. So this is medial to the internal carotid artery. This is the area we have to look for the retropharyngeal lymph nodes. Then if you have a tumor in the lateral pharyngeal recess, if it is confined to the pharyngeal mucosa, this is the pharyngeal mucosa, which confines this is the levator veli palatal muscle. This is the tensor veli palatal muscle. The tensor veli palatal muscle is lying outside the pharyngeal mucosal space. So this is a pharyngeal mucosal space. So if you have any tumor which is lying within that pharyngeal mucosal space, or the lesion is going into nasal cavity or into the oropharynx, that is T1 disease. If the tumor spreads laterally into this parapharyngeal space, this is the parapharyngeal space. Okay, the lesion is involving the medial pterygoid muscle. This is the medial pterygoid muscle. Medial pterygoid muscle is arising from the medial surface of the lateral pterygoid plate, and this is the lateral pterygoid muscle. So if a lesion is involving the prevertebral muscles, this is the longest capitis muscle, or involving the parapharyngeal space, or the medial pterygoid muscle, or the lateral pterygoid muscle, then that is a T2 disease. Any tumor which spreads lateral to the lateral pterygoid muscle, this is the lateral to the lateral pterygoid muscle. Previously, it was considered the infratemporal fossa. There is a slight difference in the terminology of infratemporal fossa, particular to the nasopharynx. When we discuss about the oral cavity and oropharynx, then that's fine. But in nasopharynx, anything lateral to the lateral pterygoid muscle, then that becomes a T4 disease. So that is T4. If you have a tumor which is spreading posteriorly, then the patient can have neck stiffness, neck pain, etc. Tumor is spreading anteriorly, then the patient can have nasal symptoms. Laterally, then you have the ear symptoms. Now, if you look into the boundaries, if this is the basi, this is a roof that is formed that is by the basis sphenoid. This is a basis sphenoid. Then you have posteriorly have the basi occiput that's found by the clivus and also the C1 vertebra. If you ask me what is the lower limit, the caudal limit of nasopharynx is the caudal limit of the C1 vertebra. That's according to the Gray's anatomy. The caudal limit of the C1 vertebra is considered the caudal limit of nasopharynx. Anteriorly, it is continuing as nasal cavity, and the roof, the floor is formed by the superior surface of the soft palate. This is a soft palate, and the superior surface of the soft palate forms the inferior limit of the nasopharynx. That corresponds to the C1 vertebra. That is the sagittal view. You can see that. So any patient who is presenting with the nasal cavity symptoms suggestive of lymph node involvement, cranial palsy, then you have to think that that's a carcinoma nasopharynx. Of course, you will go for a nasal endoscopy and a biopsy, and you will do the immunohistochemistry to see there's a cytokeratinase positive and P60, P40, whether to look for the squamous cell carcinoma. Then you will have the imaging of choice is MRI of the nasopharynx from base of skull and the neck to know the MRI is superior in certain situations. One, to know whether the prevertebral muscles are involved, number one. Number two, the retropharyngeal lymph nodes. Then look for the perineural invasion. The base of skull involvement may be better delineated by CT, but the extent of the intracranial extension, like as the previous speaker mentioned about the cavernous sinus involvement, this can all better delineate in MR compared to a CT scan. Then you should have a distant metastatic workup that can be either a single shot PET CT, or you go for X-ray chest, you go for the ultrasound of the abdomen and a bone scan. If you are going for the second approach, if the patient is having lower cervical nodes, always you should consider CT thorax and never limit that to an X-ray chest. The baseline that counts, including the creatinine clearance, and you should have the other tests like visual field texting, audiometry, EBV titer is optional. All patients should have, who are undergoing radiotherapy, should have dental prophylaxis, because that's the backbone of the treatment of carcinoma nasopharynx. And in young patients, you should have an evaluation of the endocrine, baseline endocrine function evaluation. So this is and you go straight into the staging. If you have a disease, T1N0 is stage 1 disease. That's treated by radical radiotherapy. So we'll come to that. So any tumor which is confined to the nasopharynx, this is the normal, the fossa of Rosenmuller. You can see on the left side, this is the lateral pharyngeal recess, and you have the prevertebral muscle. This is the longest capitis muscle. You have the carotid sheath here. You look for retropharyngeal lymph node here. This is the parapharyngeal fat. This is the lateral pterygoid muscle. These muscles are this is the levator veli palate muscle and tensor veli palate muscle, small muscles. Then any tumor which is confined to the nasopharynx, which is either extending into the oropharynx or into nasal cavity, that's also T1. As earlier it was not T1, but later we found out that the survival curves of lesion involving the nasal cavity and oropharynx is similar to that of the tumors which is confined to the nasopharynx alone. So that is T1, and if any node is present, it is not stage 1. So T1N0 is stage 1. The standard treatment is to go for radical radiotherapy. Any tumor which is having extension to the nasal cavity, so that's also T1. How you look for that? You look for the pterygoid plates. If any tumor which is spreading anterior to the pterygoid plate, then pterygoids, then you have to look that patient is having a anterior extension into the nasal cavity. And any tumor which is spreading below the C1 vertebra, that's also patient is having an oropharyngeal extension. That's you can make out in a sagittal vein. You need to understand that most of the nasopharyngeal tumors which spread superiorly. So any tumor which is having an oropharyngeal involvement is likely to have involvement of the lesion superiorly also, either destroying the sphenoid or extending into the clivus. So you have to look properly for that. Then coming to the stage 2 disease. Stage 2 disease is heterogeneous. It is T2N0, T1N1, and T2N1. That is stage 2 disease. So if you look into this CT scan, I will show one CT and one MR. You look, this is the normal fossa of Rosenmuller. Okay, this is the normal thing. This is the prevertebral muscles. You cannot clearly make out the prevertebral muscles in a CT scan, but you can make out very clearly in an MR. So this is the torus tubaris, opening of the eustachian tube. This is the parapharyngeal space. This is a styloid process. Okay, this is the carotid sheath. And if you look into the normal in MR, all these spaces are hypodense. In MR, so in CT, and in MR, it will be hyperdense. And if you look into this, you can see that this is a lesion involving, this is a normal mandible. You have the medial pterygoid muscle. This is downward. This is not in the inferior aspect. You can see this is a lesion is involving the medial pterygoid. And this is when the medial pterygoid is involved, then it becomes a T2 disease. You can make out bilateral retropharyngeal lymph nodes in this patient. You can make out. So this is a patient, if the patient is having bilateral retropharyngeal lymph nodes, again, it is only N1 and it is not N2. So bilateral retropharyngeal lymph nodes, it's only N1, and this lesion is extending into medial pterygoid. So it is a T2. So it's a T2N1, and it is stage 1. Again, here in CT, you can make out the prevertebral muscles are involved. Okay, so it's again a T2. The parapharyngeal fat is obliterated, it is T2, and it is extending into the pterygoids. So this is again, it is pterygoids are involved. So it is a T2 disease. So this is a T2 and this is a T2. So here you cannot make out any retropharyngeal lymph nodes. That's it. How will you treat a stage 2 disease? The standard treatment, if you look into the evolution of stage 2 disease, early it is radiotherapy, but there was a paper which published in Journal of National Cancer Institute in 2011, comparing radiotherapy versus radiotherapy plus chemotherapy. That was a 2-dimensional radiotherapy. It was found that there is an improvement in survival in patients who received concurrent cisplatin 30 milligram per meter square compared to radiotherapy alone. That is for stage 2 patients. But there was a recent phase 3 randomized trial presented in last ASCO meeting, and published last week, which shows that if you add chemotherapy in patients who are receiving IMRT, there is no absolute benefit. So in highly selected patient, whether IMRT is alone enough in stage 2 patients. Okay, so we may need more long-term follow-up that particular clinical trial. That's my personal opinion. So stage 1, it is radiotherapy alone. In stage 2, it is chemo plus radiation. In selected patients, you may avoid chemotherapy like T2N0. I'm not comfortable in avoiding chemotherapy in node-positive stage, so that is T1N1 and T2N1. And coming to the IMRT has improved definitely the survival that we will discuss. And I'm sure that my colleague, my friend, Dr. Basu will discuss that more in his next session. Coming to stage 3 patients is either it is a T3 disease or N2, that's stage 3. N2 means bilateral lymph nodes, and the patient T3 means bony involvement. Bony involvement can be either due to a pterygoid plate destruction, C1 vertebra, sphenoid sinus, base of skull involvement. Patient is having clivus destruction or a petrous apex bone involvement. All these are T3, and maxillary sinus involvement, this is also T3. All are T3, and in all these patients, bony involvement is T3. You can see that the lesion is involving the sphenoid sinus. And this patient is having bilateral nodes at the level of the level 3 because we are seeing thyroid cartilage. So it's a T3 N2 disease. In all stage 3 and stage 4 patient, the standard treatment is to go for induction chemotherapy based on 6 phase 3 randomized trials recently published within 1 or 2 years. And there is 2 meta-analysis have shown there is a survival benefit. Although the overall survival data is conflicting regarding all the 6 phase 3 clinical trials, all the clinical trials except one has met the primary endpoint, that's failure-free survival. So as of now, the standard dictum is to go for induction chemo followed by chemoradiation in stage 3 and stage 4 patients. And this may be induction chemo with cisplatin 5-fluorouracil, cisplatin gemcitabine, or a modified TPF like the cisplatin 5-fluorouracil and docetaxel reduced dose 660 milligram per meter square. And that's stage 3 and stage 4. And coming to stage 4 disease. So if you could, I will discuss before that, I will just show you a perineural invasion, how these patients have helped them are. So this, again, the Dr. Paul has clearly mentioned the pterygopalatine fossa, which is having so many connections. And one of the connections is to the infratemporal fossa to the pterygomaxillary fissure. You can see widening of the pterygopalatine fossa here. And also you can see the lesion involving the lateral pterygoid, the lateral pterygoid muscle here. Okay, this is a lateral pterygoid muscle. This is a pterygopalatine fossa. This may be due to the involvement of the V2 nerve. But if you have any bulky disease involving the medial pterygoid and lateral pterygoid, always you have to think about the mandibular nerve involvement, the perineural invasions. And you can trace that up to the foramen ovale to the foramen ovale to the cavernous sinus. So in this particular patient, the lesion is involving. This is the lateral pterygoid normal. This is a medial pterygoid here. This is a medial pterygoid, lateral pterygoid is involved. So as another important thing is involving the infratemporal fossa, because that's the infratemporal fossa lies medial to the mandible and to the level of the lateral to the lateral pterygoid muscle plates. So this the infratemporal fossa is involved, and you can see, you can trace that the perineural invasion to the level of the cavernous sinus. That's a T4 disease. So this is same patient having a V2 and V3 nerve perineural invasion. Now, if you look into the conclusions of the management, because that's my first part, then I will discuss about the radiotherapy part. So if you look into the stage 1 disease, it is a standard treatment is to consider radical radiotherapy. Radiotherapy to the primary and also the entire neck. We have a very recent data showing that in an N0 neck, you can avoid the lower neck. but you have to treat the entire nasopharynx. You have to cover the areas which are included, that I will discuss later. Then you have to cover the upper cervical nodes, bilateral esophageal lymph nodes, bilateral level 2, bilateral level 3, and bilateral 5A nodes to a low risk to intermediate risk colia. So that should be the standard treatment for an stage 1 disease. And in an upper neck irradiation and lower neck irradiation, whole neck irradiation, we have the same efficacy with less toxicity, very recently published in 2022. And in stage 2, there is no role for neoadjuvant chemotherapy. The role of chemotherapy is questioned in stage 2 disease with a publication of a recent phase 3 clinical trial. And stage 3 and stage 4 in standard treatment is to consider induction chemo followed by concurrent chemoradiation. There are 2 phase 3 clinical trials comparing 2-drug versus 3-drug induction chemo regime, and there's no benefit. You cannot clearly say that 3 drugs should be given compared to 2-drug alone. And regarding the new toy is the adjuvant capecitabine. 2 phase 3 clinical trials were presented last ASH in 2021 ASCO annual meeting. One has been published in Lancet, and I understand the other paper is under publication in the press. Both shows that there is a benefit in terms of adjuvant capecitabine, because in cisplatin 5-fluorouracil adjuvant chemotherapy main complaint was complaints, and both trials were showing promising results, although we need long-term follow-up for all the 2 phase 3 clinical trials. And this is the conclusion of the management. And now coming to the radiotherapy proper. So you have to cover the entire nasopharynx, okay, and also the areas which are at risk. So what are the areas at risk? One, this is the maxilla. Earlier it was the posterior 1/3 of the maxilla. The new guidelines, it is 5 mm of maxilla and 5 mm of nasal cavity. The woma, you have to include that. The entire base of skull, and you have to cover the lower half of the sphenoid sinus. And also you need to cover the parapharyngeal space here. The parapharyngeal space. This is the retrostyloid area, the carotid sheath. You need to cover the prevertebral muscles. So if you draw the area which you need to treat, include, this will be like this. So the parapharyngeal space, the carotid sheath, the prevertebral muscles. So you need to cover the entire area. Now, why the IMRT shows this is because if you do a radiotherapy, when you do an off spine, if you have a tumor which is involving the retrostyloid area, there can be a geographic miss. That's a real concern. So if you look into the data regarding 2-dimensional radiotherapy and IMRT, you can see that in 2-dimensional radiotherapy, even in T1 and T2 disease, the 5-year locoregional control is around 90 to 100%. In T1 and T2, the aim of IMRT is to reduce the morbidity due to treatment. But if you look into the 5-year locoregional control of T3 and T4 disease, it ranges from 40 to 70% with 70 grade. It means there is a huge room for improvement. That gap is filled by the IMRT. Because, so to conclude, in T1 and T2 disease, it is mainly to reduce the morbidity, and in T3 and T4, it is to improve the locoregional control, and it has also shown improvement in survival. So now I will come to the 2-dimensional radiotherapy planning. So this, and when I looked into the previous the conventional simulator films for that, which were not allowed, I could not access that. But I will try to give you how you will put the field and borders for a 2-dimensional radiotherapy. So in 2-dimensional radiotherapy, the fields, the superiorly, it should be the supraorbital ridge. This should be the supraorbital ridge. And anteriorly, it should be the lateral canthus. It should be a lateral canthus. So this will be the field. And posteriorly, you go a little liberal. Okay, you have to cover the retropharyngeal lymph nodes and level 5 lymph node also. And if you have nodes, then you wire it or you spare the skin there. So this is the entire, this is the posterior limit, this is superior limit, anteriorly the canthus, and anterior to the hyoid. And inferiorly, you cut, you limit, or you split the laterals to the lower anterior neck.
Hello, sir. Any issue?
Yeah, can you hear me now?
Yeah, I can hear you.
Yeah. I think there is some issue with this internet. I'm sorry. Okay, so then inferiorly you split where there is a node. Suppose if you have lower nodes, level 3, level 4 nodes, it will be very difficult to split. But at the same time, it will add to morbidity in 2-dimensional radiotherapy, because you hear the interfield distance will be around 14 to 15 centimeters. Here the interfield distance will be around, say, 10 or 11 centimeters, so or 9 to 10 centimeters. There will be a long lot of toxicity to the larynx. So when is difficulty in splitting the fields. So this is the first phase. That will be the first phase. So you will shield this area with MLC if you are using a LINAC, or you use, if you are using a cobalt, then you have to shield this with you have to shield manually. Okay, this is how this will be the field like. Then after 44 gray, that will be the second phase. Then you will do the field size reduction. So this will be the field size reduction here. And you add a posterior electron boost. You add a posterior electron boost to that posterior area. Then in that, after 22 fractions, that will be 44 gray. And then after 27 gray, so if the base, suppose you can recheck where the brainstem is coming to that, then you can you can shield that area more closely if the lesion is not invading the clivus. But if it is invading the clivus, then that will be difficult. Okay, then, so this again, you can shield that area after 27 fractions. So you can do a shielding of the spine at 44 gray or 22 fractions. Some say 40 gray, okay, that's also fine. But we used to do 22 fractions, so we can increase the dose by the lateral portals. They again shield that. So you continue that to 60 gray because the involved nodes also will be receiving 60 gray. Okay, so that will be your dose. Then after 60 gray, you boost that, the primary area, with again shielding. And if nodes are also there, you shield that to another 6 to 10 gray. That's to a total of 66 to 70 gray. So there are different techniques. If you go into the Hong Kong, the Singapore technique by the WHO, then in the second phase, they have added a lower anti-neck field also to reduce the dose to the temporal lobe and also to the temporomandibular joint. But generally, we never used to do, unless there is a huge nasal cavity extension, we never used to do that. So that is, so in the first phase, you will be the supraorbital ridge, lateral canthus. Then that will be the boundary. Posterior, you give a liberal margin, posterior to 1.5 centimeter to the node. Then lower, you split that. Then you do a off spine after 22 fractions. After 27 fractions, 54 gray, you can shield more tightly the base of skull. Then after 60 gray, then you give another 6 to 10 gray. Sometimes it will be very difficult to give beyond 66 gray plus chemotherapy in conventional radiotherapy. That's why I said 66 to 70 gray. Okay, you can push further, then you go up to 70 gray plus chemo. And at that time, before 2012, we used to give adjuvant chemotherapy. It is a lot of difficulty for the patient. So that's the two-dimensional radiotherapy. Again, there are some modifications can be done. If you do a 5-degree tilt, then you can reduce the dose to the contralateral lens. That's one area you can do that. You can shield that, the contralateral, then you could do a 5. And in certain patients, you can do an oral cavity shielding also. So you can do the brain shielding from the beginning itself. So that is how another picture. The lower anti-neck is split where the nodes, okay. So this will be the lower anti-neck with, if you are using a cobalt, then you have to give a margin for this 0.1 centimeter difference. Or if it is the monoisocentric by the MLC, then you can do a lower anti-neck. You can shield the spine and also the apex of the lung by the MLC. That is two-dimensional radiotherapy. Then looking into the field borders. So if you look, this was a tumor. This patient actually received chemotherapy. Okay, so it was included the entire nasopharynx. So this was the oleum which is after chemotherapy. And what we have drawn is the pre-chemo oleum, because in the pre-chemo oleum because whether we should go for the pre-chemo oleum or post-chemo oleum, I think Dr. Basu will discuss that. But if you can give to a dose of 70 gray, then, and there is no critical structures nearby, then you can push that to 66 gray. If there's sometimes it like intracranial extension very close to the optic chiasma, optic nerve, then you limit that to 60 gray. This is a field, this is a two-dimensional radiotherapy field. And okay, then I will show you the distribution. Then one of the concerns in the two-dimensional radiotherapy is that if you have a tumor in the posteriorly, then when you do a shielding, there can be a geographic miss. That's the reason why the T3 and T4 disease with two-dimensional radiotherapy, the 5-year local control was only 40 to 70%. The distribution, this is a small field regarding the dose of the, after the 60 gray, you give another boost of 6 to 10 gray. So that's the field for that. So this is the difference between the distribution of a 2D and an IMRT. You can see that See, entire area, you are seeing the pterygoid plates, the muscles, the mandible, the entire parotid, the masseter, all this area are receiving a full dose to that. But when you use an IMRT, you can make out a very beautiful distribution to, this was a 6468, that's 98% of the 66 grain 30 SIP technique. So this is a very beautiful, you can limit the dose to the surrounding structures. So there is a phase 3 randomized trial comparing 2D versus IMRT, and it has shown that there is an improvement in 5-year local control, but this magnitude of benefit was mainly seen in T4 disease. And if you look into the regional control, it was mainly in N2 disease, and the overall survival, it was found in mainly in stage 3 and stage 4 patients. So the magnitude of benefit of IMRT mainly in the advanced disease. The acute toxicity were also less in skin reaction, mucus, and also if you look into the xerostomia, hearing loss were less in patients who receive IMRT, and long-term complications in terms of temporal lobe neuropathy, cranial nerve palsies, and also trismus, neck fibrosis, xerostomia, and hearing loss less with IMRT. So any questions regarding the nasopharynx? Otherwise, I will go to the salivary gland. Can I have another 10 more minutes to finish the salivary gland?
Absolutely, please proceed.
Yeah. So, okay. So the salivary gland, okay, again, salivary gland, I will discuss the approach to a patient with salivary gland, the investigations to be done, a brief outline in the surgical management, and the indications for radiotherapy, evidence for the same, and the 2-dimensional radiotherapy planning. The salivary gland is any cell or organ discharging secretion into the oral cavity, and it is divided into major and minor. And the major are the 3 paired, that is the parotid, submandibular gland, and the sublingual gland. Okay, if you look into the anatomy, again, the borders has been clearly mentioned by the radiology class. Superior, again, this is again a refreshing, and that if you look the superiorly, it is the zygoma, and this is a posteriorly, postero-superiorly, and postero-inferiorly. Postero-superiorly, you have the external auditory canal, and postero-inferiorly, you have the mastoid process. Inferiorly, it is up to this level of the styloid process, and it is compressed by the sternocleidomastoid. Anteriorly, you have the parotid duct, and it is at the level of the anterior border of the masseter. So this is the parotid. And you have the submandibular and sublingual gland. Sublingual gland is nothing below the tongue, okay, sublingual space, that's a sublingual space. I will look into how to look that in an MR also. This is a submandibular gland. And the submandibular space and the sublingual space is separated by the mylohyoid muscle, which forms the floor of the muscle, the floor of the oral cavity. The mylohyoid separates the sublingual gland from the submandibular gland. But a part of the submandibular gland is lying in the sublingual space, which is coming into the sublingual space, part of the submandibular gland. So this is the mylohyoid muscle. Mylohyoid muscle is arising from the mylohyoid ridge in the mandibular aspect of mandible, and it is getting inserted into the hyoid bone. And this separates the fossa for the submandibular gland and the sublingual gland. This is sublingual gland and submandibular gland. And I will show you how to see that in an MR. So this is a mandible, okay? And all the spaces in MR will be hyperintense, and the muscles will be isointense or grayish. And this is the air will be jet black. So this is the jet black air, and this is the submandibular space. So this is a mandible, and you are seeing a space. There is enhancing area. That is a submandibular space. This is submandibular space, and this is the medial to that submandibular space. That's a muscle called the mylohyoid muscle. This is a mylohyoid muscle. So then between the submandibular space and the mylohyoid, you have the sublingual space here. This is the sublingual space. So between the sublingual space and the submandibular space, you have the mylohyoid muscle. And the medial to that, this is the hyoglossus muscle. This is a hyoglossus muscle. This is a lingual septum of the tongue. And this is a genioglossus muscle. So I'm not going to that because that's not area of our interest. So this is a sublingual space. This is submandibular gland. How you look in an MR. Now, when you approach any parotid swelling or the submandibular swelling or a minor salivary gland, you need to understand that 3/4 of the tumors, 3/4 of the tumors are benign in parotid. So most of them are pleomorphic adenoma. But in submandibular gland is around 50%. But in minor salivary gland, if you have a tumor in the minor salivary gland, it's mainly around 80%. That's 4/5 is malignant. Okay, that's how clinically you have to understand. So how to approach a malignant parotid tumor? So you have to do a proper clinical exam. Say for parotid, you should have a proper emphasis on the fixity of the mass. What is the consistency of the tumor, whether it is hard, whether you can make out the borders, what about the fixity, whether the patient is having any cervical lymph nodes, what about the facial nerve involvement, whether the patient is having any trismus. These are the important things you have to look when you take a clinical examination for a parotid tumor. And the first and foremost thing is you do an FNAC, preferably a guided FNAC. And if you do that, then you will have an idea whether you are dealing with the malignant tumor or benign tumor. If it is malignant, definitely you can discuss, and perioperatively you can take a consent for a total conservative parotidectomy, then plus bar minus whether to consider a prophylactic neck dissection if it is a high grade. All the discussion can be made if it is you do an FNAC. And the imaging of choice, like in nasopharynx, it is the parotid is also MR. So never think that MRI is the investigation of choice for the whole the head and neck. In nasopharynx, the parotid region, oropharynx, preferably paranasal sinuses, the MRI is the investigation of choice. In the oral cavity for tongue and floor of mouth, MRI is the investigation of choice. For gingivobuccal complex tumors, in larynx and hypopharynx, CT scan is the imaging of choice. So in parotid tumor, MR is useful compared to CT in different ways that I will discuss. Then X-ray chest and routine blood parameters. And how MR is superior in patients who have perineural invasion, base of skull involvement, parapharyngeal space, and those who are arising the deep lobe can be better delineated in MR compared to CT scan. But if you have a mandible involvement or a temporal bone involvement, CT scores over MR. And this is a very beautiful review article which published in Oral Oncology a few years back in 2017. The surgical treatment for salivary malignant tumors. I urge all the residents to go through this because you should have an idea what surgeon is doing. Then you can discuss and decide the adjuvant treatment and plan radiotherapy accordingly. Superficial parotidectomy means you have to know what are the certain terminologies. The superficial parotidectomy means to remove the gland superficial to the plane of the facial nerve. Means between only the superficial lobe is removed. And this may be done in malignant parotid tumor in a very highly selected cases. Because if you have a high-grade tumor, prefer to have a total conservative parotidectomy. If a patient is having low-grade tumor, very superficial tumor, then you may get out with superficial parotidectomy. And it is not involving the facial nerve or the deep lobe. This classic surgical procedure for a malignant parotid tumor is total conservative parotidectomy. For the tumor extension into the deep lobe of the parotid, when the primary is arising to the deep lobe, any tumor with a high-grade tumors, and the patient who have lymph node metastasis, or if the patient had undergone a superficial parotidectomy and margin is positive, and then the standard treatment is to consider total conservative parotidectomy. And you try to preserve the facial nerve, and if not possible, you try to preserve the branches at least when you do proceed through the surgery. And when you go beyond the total conservative parotidectomy, like radical parotidectomy means you remove the entire parotid gland. And in this, the patient presenting facial nerve damage. So you are not able to preserve the facial nerve. That means you sacrifice that. That's T4 disease in radical parotidectomy. When you go beyond that, especially in two situations, one, the patient is having skin involvement. Then you have to do a reconstruction there. Then you go beyond that. That's called the extended radical parotidectomy. When the skin is involved, the mandible is involved, or the temporal bone is involved. Anything beyond the whole node, whole gland and facial nerve, then that becomes an extended radical parotidectomy. So the terminologies are superficial parotidectomy done in highly selected superficial low-grade tumors. The standard surgical procedure is total conservative parotidectomy. Then you have the facial nerve is involved. You try to preserve the branches at least. If not possible, then only you should sacrifice that. Then it becomes radical parotidectomy. And next is extended radical parotidectomy when you remove the bone or the skin. Then after surgery, you should have a proper clinical examination histopathologically to decide the adjuvant treatment. What is the tumor site, the laterality, the histological type. Grade is also important because grade of one of the factors in head and neck, where in parotid tumors, one of the site where you decide on adjuvant treatment. The tumor size, any tumor more than 4 centimeters, that becomes T3 and it becomes an indication for radiation. If any patient is having perineural invasion, the lymphovascular involvement, additionally any other pathological findings. What about the margin? This is also very important. Suppose if a patient is having a low-grade tumor, small tumor, margin is positive, then you have two options. Either you do a revision, you do a repeat MRI after 6 weeks preferably. Then if it is a macroscopic disease, you go for a revision surgery. If not, you discuss the option of adjuvant radiotherapy. Okay, that should be in a low-grade situation. In high-grade, if the margin is positive, the question is whether macroscopic disease is left behind or not. The macroscopic disease is left behind, you have to do a revision surgery followed by a planned post-op radiotherapy. If not, then definitely this patient requires adjuvant radiation. And also you have to look into the lymph node, which is the lymph node station involved, how many nodes are involved, any extracapsular extensions present or not. Then coming to the adjuvant treatment and what is the guidelines and what are the indications for that. Now, when you look into the adjuvant radiotherapy for high-grade or locally advanced major salivary gland tumors, this was a SEER database published in 2011, have shown that in multivariate analysis, there is an absolute improvement in survival in patients who received adjuvant radiotherapy. In all patients, that is locally advanced high-grade tumors and any high-grade tumor, there was or any locally advanced, there is a huge benefit if you add radiotherapy. So the dictum is that you give adjuvant radiotherapy not alone for local control, it is for improvement in overall survival. If you look into the high-grade tumors, the hazard ratio is 0.65. There is a 35% relative reduction in death in patients who received adjuvant radiotherapy compared to no radiotherapy in high-grade tumors. And this is SEER database. Again, it is a national cancer database, which is published in 2017 in Advances in Radiation Oncology. And it also shown that those patients have extracapsular extension or a margin positive, that is considered high risk. And those patients who receive radiotherapy, there is an improvement in survival in patients who receive radiotherapy compared to no radiotherapy. Now the question is that what about the minor salivary gland tumors? Whether it is the data is confined to the major salivary gland tumors, whether the benefit is confined to the benefit is there in minor salivary gland as well. This again data published in Oral Oncology in 2015 from a SEER database from 1988 to 2008, around 2,200 patients. The maximum benefit was seen in patients who have advanced stage and high-grade tumors. And this patients are received, they say hazard ratio, sorry, p-value is 0.02, and it is for survival. There is a survival benefit. Again, in high-grade tumors and advanced stage, minor salivary gland tumors after surgery. Now, what is the role of chemotherapy along with radiation? This is a JAMA paper which published in 2016 that the association of adjuvant chemotherapy, it can have a negative impact, although this was not statistically significant. Shows that those patients who receive chemotherapy along with radiation, there is a trend towards reduction in survival. And this p-value was not significant, but there was no outcome. There is a trend towards detrimental effect. The R2G1008 is a phase 3 randomized clinical trial. Initially, it was a phase 2 change to phase 3, comparing role of radiotherapy versus radiotherapy plus chemotherapy in patients with advanced disease T3, T4, or patients with node positive or margin close or positive patients. This is underway, and this may give you an idea what's the role of adjuvant chemotherapy along with radiation in high-risk patients. Now, coming to the indications for adjuvant radiotherapy, this T3, T4 disease and node positive disease, patients who have high-grade histology. High-grade histology means salivary, adenoid cystic carcinoma, high-grade mucoepidermoid carcinoma, undifferentiated histology, adenocarcinoma, squamous cell carcinoma, adenosquamous carcinoma, undifferentiated carcinoma, and the salivary duct carcinoma. These are the high-grade histologies. Any patient with margin positive, in patients who have low-grade tumors, T1, T2 disease, and if a macroscopic disease is left behind, then you prefer to do a revision surgery and avoid adjuvant radiation. Otherwise, you give margin positive or margin close and indication for radiation. Any recurrent tumor, if the patient had a PT1N0, PT2N0, margin negative, no PNI, no LVSI, there was no indication in the beginning, and patient was kept on follow-up, there was a recurrence. And irrespective of the size and grade of the tumor, after revision surgery, patient should undergo postoperative radiotherapy and any perineural invasion or lymphovascular involvement. So to conclude, any patient who have a PT1, PT2, N0, margin negative, no PNI, no LVSI, and no high-grade histology, and this patient can be kept. Otherwise, all patients should have adjuvant. Now coming to the borders, two-dimensional radiotherapy planning. So this should be the superior. I said this is the zygoma. This should be the zygoma. It should be top of the zygomatic bone. And posteriorly, it should be the mastoid process. Inferiorly, it should be the hyoid bone. And anteriorly, it is anterior to the clenched masseter. So that's the field. That's the last standard dose is 55 to 60 gray. And standard recommended dose is 60 gray in 30 fractions. So if you look into the fields, so this is a 3-field technique. Okay, this was treated a few years back. So this patient was treated with three-field technique, one lateral field. The anterior limit will be the anterior to the clenched masseter, posterior to the mastoid. So this will be the limits, superiorly to the zygoma, inferior to the level of the hyoid. And you have the anterior oblique field and you have a posterior oblique. This is the anterior oblique field. This is the anterior oblique field. And you have the posterior oblique field. This is a posterior oblique field. Okay. So when you tilt more, so the anterior and the posterior oblique are wedged fields. And when the patient is having a skin involvement or very superficial tumors, margin is close or positive in lateral aspect, then you add a bolus. Otherwise, you need not need a bolus. Okay. Then you can use the wedges for the anterior oblique and the posterior oblique fields, usually 30 to 45 degree wedge. And the tilt is also very important. When you increase this tilt, the oral cavity will increase the high dose to oral cavity. When you tilt more, the brainstem and spinal cord will receive high dose. So it has to be, it should be, and all the independent fields should cover the CT. Okay, so this is the to cover the entire the parapharyngeal space, and this posteriorly you should cover the retrostyloid area. This area should be covered posterior to the mastoid, and you have to include this area. Okay, so this parapharyngeal space should be included in the CT. Now for this, I'm not very familiar with because this technique which is given in Paris, okay, to be very honest with you, this is a 2 obliques. You can use a 2 oblique, but in general in our institution, you use 3 feet, 1 2 lateral beam, one anterior oblique and a posterior oblique. So you can use get away with 45 degree angle 2 anterior oblique beams also can be used. And you can also use the mixed beam. That's a very beautiful thing because this can reduce dose to the opposite parotid and also to the oral cavity because you use a 6 MeV photon and a 12 MeV electron in 1:4 to reduce the dose to the spinal cord, opposite parotid, etc. So this will give you a very beautiful distribution. Again, I will show you what's mixed beam, which we have done in our institution. So this is, again, you can reduce the dose to this area. So this is the photon and electron mix. Now I'm encroaching into Dr. Basu's area. Okay, I'm sure he will discuss about the COSTAR guidelines because that's the new norm. Because you can spare the cochlea, you can spare the cochlea, you can spare cochlea sparing IMRT is the norm in the post-op IMRT. Okay, coming to the elective nodal irradiation in all these patients in high-grade tumors, because whether elective neck dissection should be done in T3, T4, or the patients who have high-grade histology, that's a matter of debate. There is no consensus. You can debate from morning till evening. There will not be any consensus. But the same with radiotherapy also. And in a part of the level 1B and level 2 comes in the CTV of the parotid, because the lower limit is at the level of the hyoid bone. Routinely, we usually do not irradiate the level 3, level 4, or the level 5 regions. But if the patient is having any node positive disease, especially in level 2, 1B, or in level 3, the whole neck has to be given a lower dose to a 50 to 54 gray column dose. That should be given. So that should be given if the node is positive. Node negative, it is optional. There is no clear consensus. You can argue in high-grade tumors, lower neck should be given. Again, there is no clear evidence for that. Even for surgery, there's no clear evidence. I sincerely thank the organizers again for the invitation. I'll be very happy to take few questions. Sorry, yes, whether I have exceeded my time.
Thank you, Dr. Sezel, for an excellent lecture on the 2D aspects. I know it is not very easy, especially for residents now who are getting trained in the 3D environment. And this is the reason why we have opted for this course specifically. So may I just request if it is possible for you to stay for the remainder of the class, it would be better if we could take the questions together after Dr. Basil's talk, because some of them might be overlapping. Thank you so much. So can I now invite Dr. Triranjan Basu my dear friend to take on the class for the 3D aspects today.
Hi, Abhishek. Thank you, AROI West Bengal, Abhishek and Costa for the kind invite. And it's a pleasure listening to Dr. Sesal. Once he speaks, I feel like there should be no stoppage. He should have taken my talk as well. So I have been given a very tough job to do conformal planning discussion for nasopharynx and salivary glands. Maybe salivary glands I have to rush through. Nasopharynx I try to cover a lot of practical aspects. So sir. Yeah. So these are the basic points I have covered. Essential, a bit of background knowledge about how the transition occurred from the simpler radiation techniques to IMRT onwards. A brief overview of the targets and OR, specifically the practical aspects. Like Abhishek some time back said, it's very difficult in a lecture to discuss about the guidelines in details, and they are freely available. So with an excellent radiology, and after Dr. Sesal's talk, one has to read in detail and multiple time to understand that. I will also touch upon the plan evaluation, how it is done in IMRT, and what are the technical details related to that, both for the target volume as well as the OR, and few case-based discussions and few challenges for me working for last couple of years as a resident about a decade back, what challenges I felt after the transition into the IMRT. So a few of those basic points. So I call nasopharynx to be a Pandora's box. We know the basic anatomy, it's been discussed already. The unique anatomical challenge remains between covering the adequate target volume and sparing the critical organs at risk. Radiotherapy remains the mainstay, as we have heard already. So this is the transition between the 7th to 8th edition of the TNM. This is important to know. Dr. Sesal has beautifully highlighted also how the T and Ns have changed. What initially used to be for an N3 supraclav, it has changed to a more anatomical boundary, more of a CT base with the cricoid cartilage border, how the T1, T2, T3, T4s have changed also. So this is important to know before we jump into the contouring details. Now, this is the TNM 8th edition, and stage 2 also to highlight, as Dr. Sesal also highlighted, that this is different compared to other head neck cancers, where in stage 2 we also have N1. Now, talking about the transition, this is a long back paper in 1990s, where actually people have tried in their conventional plans to superimpose and do a 3-dimensional planning. And it is so nice to know, when I was going to the literature way back, 30 years back, almost more than that, these concepts were existing actually, what we read as guideline, which I'll come to my presentation in some time, that you have a gross disease, you have a certain margin for the highest dose, then you have a so-called subclinical high-risk disease and a subclinical low-risk disease, similarly for the node. So the same things are applicable. The difficulty was not the availability of technology, basically. So people were delivering close to 70 gray also at that time. Then this also been highlighted in my previous lecture. So the Canadian group has done an limitation analysis. This got published in 2003. This is also a 4-phase treatment techniques reaching close to 66 gray. And if you see that more we have higher stages and more of posterior disease, the more is the chance of miss. And that is what is the challenge. Now, a transition between 2D to 3D to IMRT, and then we have a phase 3 randomized data of comparing the outcome as well as the toxicity. And these are the important points which I've tried to highlight in terms of local control, regional control, and overall survival. The more we go to the higher T stage, the more we go to the higher N stage, as well as the stage grouping, the importance of IMRT, and between the IMRT and the 2D group, you can see the p-values, how they are changing. So the take home would be the higher T, higher N stage, and the overall higher stage. This is definitely a benefit of IMRT. And this is one of the sites for the resident to know in head neck cancer, where you have a randomized evidence of IMRT. Now, similarly for the acute complications as well as the late complications, especially related to xerostomia in acute as well as late, the hearing loss, the acute as well as the late, and the dreaded complications of like temporal lobe neuropathy, the cranial nerve palsies, the optic structure injuries, they all can better be saved by IMRT. Now, this is a decade back a review by Nancy Lee group, where they have collated all the IMRT and the 2D series. So if you see across literature in the IMRT between the local and regional control, they're excellent. In all states combines also, it is between 80 in some series, reaching close to 100%, the local regional control. Albeit the distant mates with the higher state would be bit more. Similarly, in the 2D, you can see at times they are very dismal to less than even 30-40% also, so as the overall survival. So are there any setback? We talk about IMRT also. So this is a very nice paper. I urge all of you to read, and this is from Ann Lee group, who has given the contouring guideline also. So the more we evolve to the IMRT era, there's a steady increase in local control, local regional relapse-free survivals, and the overall survival as well. Sometime in 1950s, which was 30-40%, it has gone up to 85% also. We have better treatment compliance across data. More than 90% people can complete the planned dose with concurrent chemo minded and maybe also NSCT or adjuvant. It definitely given us a favorable acute and late toxicity profile. The caveat remains maybe the dismal outcome in T4 and the concerns about the distant metastasis. Now, after a 10-year data, if you see for a very large cohort and long term, if you see in all stages between 2D and IMRT, there's a definite benefit. In the timeline, if you see, the more IMRT keeps on increasing, and it has now been standard without any doubt in treatment of nasopharynx and almost all other head and neck cancers. Nasopharynx for sure. So what we have learned from all this is that, the radiotherapy been established a long back as a treatment modality for nasopharynx. Initial data suggested about 50% of the 5-year disease-free survival, which has increased more now. The first ever IMRT report was from UCSF in 2000, which reported 100% local control and 4-year overall survival of 94%. IMRT has given us better conformality, more sparing of wear, and ability to deliver the tumoricidal dose, which from one of the articles should be more than 66 grade. And the superiority been proven over 2D or 3D RT in umpteen number of literatures. And we also need to add chemotherapy either as a neoadjuvant or adjuvant, and definitely also as concurrent. So coming to the radiotherapy planning part, there are a few important points. One is to do the staging properly, which we discussed already in previous lectures also. Do an analysis and understand about the patterns of spread. Select the appropriate imaging also in the planning system. Identify the skull-based foramens, the radiation planning simulation, and the image fusion. So I'll try to give few practical examples related to that. So this, we have already seen the anatomy, how on a sagittal anatomical, on an axial CT it looks like. These three important structures also already been discussed. And this is a kind of repetition of the same. And these are the patterns of spread roughly. So it can go anteriorly, laterally, posteriorly, and as it spreads, there are different structures, very important structures are risk of involvement. And they spread through the skull-based foraminers, which if we go back to our anatomical knowledge, maybe it was better identified. And in a radiological CT, remember, this looks very nice always. If you see these foraminers in a radiological CT, it looks excellent. For over a 10 years experience of working also, still I have to go through and see it, to be very honest. It looks very honest, very nice at the time, and you feel, oh, we'll be able to identify. You sit here on radiotherapy planning stations and then it gets very difficult, and I'll show you also in practical example. And these are the spaces which are also discussed. So these are very important. The pterygopalatine fossa, the Vedian canal coming to foramen ovale, the foramen spinosum, as well as the foramen lacerium. So these will be important in the CTV coverage as we move along. So we acquire the radiation planning scans, and the previously done MRI and PET-CT both play an important role. We mostly do a head and neck cast, 4 or 5 clamps, depends on your institution, hands by side. I do recommend the shoulder retractor. Neck should be in a neutral position. The planning CT scan should be with contrast, with a 2 to 3 millimeter slice thickness, and try and use all additional imaging in your image fusion. Though there are challenges to that, it can be altogether a separate discussion, but yes, they are needed. Even if you're not able to fuse them, because many centers maybe have difficulty of doing the scans at a different place, their diagnostic scans, the couch limitation and all these, but they should be available by the side while you're contouring. So for radical per primum, the baseline MR and PET, if both available, then to be used. For a post-NSCT scenario, the pre-NSCT and the post NSCT. The ideal would be having MRI and PET in both the scenarios, but we do have logistic concerns. Most of the time it is MRI PET followed by a PET or an MRI alone. So whatever is available, try to use and fuse it. If not, at least have them by the side. And it is very common, even working in my center also, most of the time you have PET and only and one MR. So these are radiopedia type images, how it looks, why the importance of PET and MRI. And you can very well see in PET, there may be a limited GTV PET uptake, but you always have to see going back to the MRI and what part you're missing. If not, then in your CT, you need to adjust that. And the window setting has already been discussed while we'll be considering the foraminers. Now, there's a very nice paper sometime back called CB-CHOP. This is a very nice acronym to evaluate radiation plan. It also highlights the contouring points. So CB-CHOP, the acronym stands for contouring. You need to know your target volumes and OR, the beam arrangements and fields, the coverage and how to evaluate them, the hotspot, the heterogeneity of the plan, the organs at risk, their constraints and how to evaluate them as well, and what dose you're prescribing with what dose per fraction and what sort of image guidance you're using. So we'll try and see all of them in some practical points. So for contouring, it is essential in IMRT planning to know the contouring well. You have to do your simulation, which is something should be reproducible with an adequate immobilization. And as discussed, fuse the images, delineate your gross tumor volume, clinical target volume and PTVs and OAR, and always review your contour. Someone who is starting IMRT contour for nasopharynx, I would always suggest, I do it myself still now also. If a day I'm contouring, I try to review it on the next day again. And most of the time there will be some editing and before you give it, because it is very, very important. This is one highly radiocurative cancer. Now, the nomenclature, as the guidelines suggest, should be consistent. You have to name the GTV tumor or GTV primary, GTV node separately. If there's a GTV pre-chemo, that also, if there's an adaptive GTV, all nomenclature should be uniform. And a CTV 1 or 2 will come to that. What is important, that should be named properly, same as the neck nodal. Dose prescription can be in a SIB or a sequential manner. We have to deliver a 70 gray equivalent to the gross tumor with a margin. So that can vary as per institute and protocol you're following. Now, we have to discuss, once we're discussing of the last international guideline for the CTV delineation of nasopharynx. So this is a sort of a Danish Head Neck Society 5+5 concept of other sites, which is extrapolated. The GTV, on a nutshell, the gross tumor volume with a 5 mm margin should be receiving your full dose until there's some challenge. We'll come to that. And there are wide variation in practice across different societies and their guidelines in nasopharynx. The suggested guideline documented all of that. The one important thing is here, whatever you follow, the consistency remains the key. So the GTV tumor and the GTV node should be documented separately. If post NSCT, then also try and draw the pre-NSCT volume as GTV pre-chemo and the current GTV as GTV post NSCT. Use your MRI and PET judiciously. Then a CTV1 would be GTV plus 5 mm margin. You can see across different literatures what guideline they have given. It is mostly GTVs as 5 mm and also covering the whole nasopharynx. Now, where the modification comes is in relation to the important organs at risk, especially the serial structures. Now, for post-neoadjuvant, that always has remained a debate. We have one long back publication from Salama et al. That for non-nasopharynx, and it suggests that all baseline disease should be the inclusion. It more or less remains same for nasopharynx, as Dr. Cecil was also highlighting, except if it is close to a serial organ at risk, which can have a permanent damage where you need to modify. Your skull base should be for full coverage, irrespective of your post-induction status, because that might not be the true reflection. And there at times there is soft tissue displacement by the tumor, so that you need to adjust. Now, the pre-NSCT GTV should at least receive your CTV 2 dose. What is that? I'll come to that. In different publication, it should be between at least 64 to 66 rate. So we should try and give the prescription close to 70. But because of the modification of this important organ at risk, at least this dose we have to deliver. Now, next comes the very important, the high risk subclinical disease. And this CTV, what all structures to be involved in that. This is the most important thing in nasopharynx, because this is different from other head neck sites. So roughly in a nutshell, it should be the entire nasopharynx, the anterior third of clivus if not involved, the skull base, different foraminas, and there are different variation depending on the T staging also. Now, again, different societies have given their recommendations. If you go to in detail in your spare time, it is not very different. I feel this is more of an institutional and a practice-based change. So let's see it. The general concept would be CTV 5+5. There are definite editing required from the serial organ asterisk and the natural barrier. Now, the CTV P1 would be your GTV plus 5 mm versus whole nasopharynx, and there are a whole lot of debate related to that. I would say practically try and cover the whole nasopharynx until there is some very important organ at risk. Now, the challenge again remains, especially in the post-NST scenario, because we see mostly node positive and advanced diseases. Now, in that, the soft palate may be spared after your post-NST scenario. Remember, the caudal border would be C1 lower border. Then the CTV P2 would be CTV P1, what you have contoured, plus 5 mm, and then include these important structures. Now, what are they? Superior, in a nutshell, this is a very long article. That's the important pointers would be superior would be vomer or ethmoid sinus. The sphenoid sinus would be T stage wise, like lower if you have the T1, T2. If you have T2, 3, 4, then maybe the full. Similarly for cavernous, if involved and higher T stage, then the ipsilateral side. The skull base foramina, irrespective of the stage, remember you have to cover the bilateral, oval, rotundum, and the lacerium. And the jugular and hypoglossal, depending on if it's a posterior extension of disease or a direct extension of disease. Now, anteriorly, the 5 mm concept has come into play now, the posterior nasal cavity and the maxillary sinus, essentially to cover the pterygomaxillary fissure and the pterygopalatine fossa. Laterally, cover the pterygoid muscles by margin and entire, if it is involved, the entire parapharyngeal space needs to be covered. So I would suggest for residents, it is still okay to be 2-3 millimeters more than trying to be too conformal and do an conformal avoidance. So it is important to cover and try to cover this well. Now coming to the GTV node, again, whether it is a primary, they name as GTV node, or if it is a post-NST, delineate accordingly to the primary, and you can add a margin for the CTV N1. And these are the guidelines of different neck nodal levels and what you have to cover. There'll be similarly an N2 and then the whole neck nodal involvement and the different neck nodal involvement in nasopharynx. Important for nasopharynx is a neck nodal would be a separate lecture altogether. But one important line is nasopharynx is something in low risk also. If it is node negative, we end up treating the bilateral level. The levels might vary, as you can see on these publications. But yes, we have not still evolved in nodal sparing or ipsilateral neck for nasopharynx. It's a midline and it needs to cover the both neck. Now coming to few practical challenges, this is a real patient data. So this was a locally advanced nasopharynx. After the NST, we tried to fuse the CT-MR and determining the lower extent. So it is always a challenge. This was the patient whose disease was coming down till the soft palate level. So if you see on the left-hand side, it is a fused CT-MR image. And if you see the MR separately in the corner, then you can see how beautiful it is delineated. So there comes the importance of MRI to determine what would be your extent of the gross disease. Similar thing happened on the upward coverage also. So if you see the left, the CT, there are two volumes. I don't know whether it is visible properly or not. One is the GTV post-NST, which is the lighter one, and other is the GTV pre-NST extrapolated. And then this patient had this basal erosion. So once we're trying to cover in CTV, then the window setting again becomes important because you have to adequately cover the clivus and you have to go back to a bone window, remember. Now, if you have a PET, a pre-NST PET and post-NST fusion, so these sort of things you encounter. So this was, if you follow the arrow, is the pre-NST PET, which is fused with the post and the planning scan. And of course, you'll not see disease, it has shrunken, but it has shrunken and there's some uptake anteriorly also. So it is not that the disease has progressed, you have your report also, but it is due to some other physiological uptake also. So this you have to edit. So I've kept purposefully, this is before the editing, that we at times just rely on the PET and try to contour without realizing that how the disease has responded, what are the natural barriers. So if the disease has responded, it will not certainly go anterior in this volume. So this you need to carefully evaluate and edit. Now, again, there are changes between CT and MRI and PET. So if you see, you have to edit eventually coming back to your radiotherapy planning CT scan, because that will be the one which will have electron data for plan calculation you'll be giving to a physicist. So edit it well. Don't just blindly rely on fused images. Now, the visualization of foramina, it looks very nice in Radiopedia, and these are real patient data. So even after the changing anatomy on all, it becomes very difficult. So if you follow, I have tried to draw them, the pterygomaxillary fissure and all, you can see the foramen spinosum. The oval was very difficult to visualize. Remember, just as a thumb rule, if you're able to visualize spinosum, the oval would be a medio superior to that. So if you're able to cover that in your volume, you have less chance of missing it. Now, again, in PET fusion, if you see pre-anesthesia and post-anesthesia, how the volumes are changing. So be cautious in covering the actual disease. Similarly, this was a post-anesthesia and you have overlap with serial structures. So you fuse the pre-anesthesia and post-anesthesia, and what I do, try to create a combined GTV and then add a margin and try to cover the whole nasopharynx in the prescription isodose and just edit from the serial structure. So don't try to edit your contour volumes, I would say. Even in the overlap with very minimum margins, add a PRV to your serial organs always. And then in evaluation, you might accept with underdosing. I'll come to that in plan evaluation criteria, but don't under contour. That will be a very disastrous thing. Now, coming to the neck in nasopharynx, few important point, we see these which are very different in nasopharynx. Like you can have enlarged retropharyngeal lymph node, you can have intraparotid lymph nodes. So be very careful in evaluating these scans. These are very few points once someone start contouring in a mid-neck level. These are the important structures you need to see. And once you start at the base at origin, this is how the internal carotid artery and internal jugular vein would look like. You come to the mid-neck level and they will be looking like this. Now, this is at the level where you're starting. These are given in RTOG Atlas, how you start the nodal contouring. This would be the level where you have to begin the retrostyloid area that you need to cover. This will be in the 19 update wise a level 7B. You come down, look for the C1 vertebrae, and you'll be able to see the retropharyngeal would be level 7A. Further come down the level 2 and 1B and the submandibular gland you'll be able to see and you'll be able to contour. Then further coming down level 3 and then level 5, which will start at the cranial edge of hyoid bones. And further you go down, there will be level 4B and the level 4 at the caudal edge of cricoid, which will be 4A, and further coming down will be 4B. And this will be level 5, which is divided between 5A, B, and C by a plane above the transverse cervical vessel. You need to identify that to be able to see it. These are, so see, very important thing. These are purposefully put. The top one is from the Nancy Lee guideline in the contouring book. And you see how in a nasopharynx, the level 5 is covered the whole of the host triangle. Purposefully, this is done by one of a resident. You see the one of the side, the level 5 is covered well. And this side where I've kept the arrow, this was missed. So this is a very important thing in nasopharynx. You have to cover the entire host triangle. So be very vigilant while evaluating the contours in that. Now, the CTVN, this we discussed, we can skip for the time being. There are certain gray zones definitely for node positive nasopharynx. In the post-induction area, the retropharyngeal lymph node, whether you also need to cover the medial one. So I'll give you two examples on these nodal we're discussing. The first one is a 71-year-old female, no comorbs, diagnosed as T2N2 EBV positive undifferentiated nasopharynx. The baseline PET-CT at T2 disease, parapharyngeal is involved, bilateral level 1B to 3 nodes, but less than 6 centimeter. Received weekly NSCT by her medonc in view of age, responded well. There were a partial response both in primary node, and then planned for a radical CTRT 1733 in a SIV fashion. So this is the pre-chemo node, which is that PET-CT is fused with the planning CT scan. And the post-chemo, you can see a very, very minor residual bin left. But those areas, then you have to add a margin and cover in at least your 64 to 66 volume. Now, the CTVN, the 59.4, since I follow that dose protocol, would be bilateral, retropharyngeal 1B, 2, 3. Why 1B? Because the initial node was encasing almost to the 1B level. This is still a matter of debate. And 4 and 5 can be kept in low risk. Sorry. Yeah. So some important point, level 7, which is the retropharyngeal, is also gets included in CTV primary in almost, except for the caudal end. There's definitely a practical challenge. You read the guideline, the RTOG atlas, it looks very nice, but practically retropharyngeal, for an elective retropharyngeal area, it gets very difficult. The primary volume eventually encompasses the retropharyngeal, also the retrostyloid area. So still one needs to be vigilant. We can avoid the medial retropharyngeal lymph node if they are not involved. And 1B is a matter of debate still now. So this is what I try to show with the arrow to avoid the medial retropharyngeal lymph node in the contour. And be very cautious on the retrostyloid area in your volumes. One should not miss that area. Now the case 2 was a 25-year-old male, no comorbs, diagnosed as undifferentiated T2 nasopharynx N0. The baseline PET-CT parapharyngeal disease with oropharyngeal extension and bilateral very, very small nodes, but not PET-avid. Now, this always remains a debate. Those nodes had no corresponding CT morphological changes to be an involved node. So we planned for a directly chemoradiation radical with a 3-weekly cisplatin within. And this is how the nodes look like. So GTV nodes, the size was a bit more, there were no uptake. So we ended up still covering them. Also on the left side, I covered 1B because it was almost touching the submandibular gland. And this is how the final volume would look like. And the submandibular gland being marked. A very, very important where I've kept the arrow is I have seen people missing while drawing the 1B, the area anterior to the submandibular gland. Remember, 1B is not submandibular gland alone. It is a space, and this space needs to be covered very, very well. Now coming to the organs, that is, there are umpteen number in nasopharynx, and some are very, very important. In fact, all are important. And this is the order mostly of in the time of importance. So then in this CB chop, we have come to this area now. So there are serial versus parallel organs. There are delineation guideline. I myself have a publication in a book chapter. So this needs to be really read in time. It is not easy to cover in a lecture, the organs at risk. I can skip through them and come to a few important points. Yes. So this one is very important because they are interlinked, the contouring, the eventually your organs at risk, your plan evaluation. So a few years back, the international guideline been published on those prioritization and acceptance of plan criteria in radiation therapy for nasopharynx. And these are the priority categories. Remember, the priority ones are brainstem, spinal cord, the optic chiasm, and the GTV. And PTV for nasopharynx goes to a priority 2 with temporal lobes. And the other OARs, which we keep on discussing in head neck cancer, like the larynx, the parotids, they fall into a priority 4 for nasopharynx. Now the beam arrangements, we can skip that. This can be decided whether you do sequential or SIB. I'll come to that. Coplanar, non-coplanar, dose criteria, whatever you're following prescription. So one important in ICRU 83 wise also, while you evaluate these plans, a D50%, D98%, which is near minimum dose, and D2% we are near maximum dose. These are now important parameters and not the other what we used to see, the D max and D mean. The GTV coverage also should be similarly evaluated by D98%, D2%, D50%. D50% would be the absorbed dose, the hot and cold spot location, and the DVH parameters. So this is what I meant by D98 and D2%. And these two clinical scenarios, we can see how we are evaluated in this. So this was the first case where, the case was a T3N1, the patient had clival erosion, received NSCT. Post NSCT was near complete response. And this is the contour finally looks like. And you can see there's a clear gap also in sagittal between your final volumes of the high dose and the serial organs with their PRP. So this is something the plan evaluation would look like when somebody opens in the planning system. And this is important. I thought I put these steps also one can see this lecture. I had one ICRO lecture last year on nasopharynx plan evaluation. So on your, this is from the Eclipse planning station. So if you click on the dose, right click, you see an absolute dose, click on that. And then you have all these parameters. You have to see all the 3 planes, the dose evaluation, as well as by your DVH parameters. So what I do, try and hide the DVH for all structures, take this crosshair, put the absolute dose and try and evaluate as per the guideline one by one. And this will be all you'll get from your planning system. So in that, the GTV should receive more than 66.5 gray, and this is what we are able to achieve. The final recommendations are given what it should be. And this is how you need to see the D98 and the D2%. Also important, you need to check for the Dmax location where it is coming. It should not be close to the serial OARs. You have to ask your physicist to change that location by running the plan once more. This is how the PTV coverage will see and accept. The D50 also, which will be close to 1% variation from your prescription dose. Now, the priority 1 OARs, which are brainstem, spinal cord, and optic chiasm, because damage to them would cause severe morbidity. So we need to add an PRV to them always. The document Dmax is actually D0.03 cc. They have priority over the target volume, except GTV remains the priority 1. And these are the final recommendation. We can go beyond 54 also if there are lower volumes of that, accept also. This is how you'll evaluate and see the OARs. In case 1, what we achieved for priority 1 and 2, you can see these are the dose we were able to achieve finally, and with the GTV D98 also, and PTV D98 even with a very good coverage. The temporal lobes which receive the max dose less than, we try and should be below 65. Some recommendations say below 62 also. This was important thing to know, is possible because the final volumes are away from priority 1 structure. And these are the other OARs. I have marked the priority 4 in red. So for a nasopharynx, I really don't try to prioritize my parotids or so. The parotids, one might say, has received higher mean dose than what is accepted in other head neck. But for a node positive nasopharynx, which is a very curative disease, it is okay for a priority 4 to achieve whatever LRA principle you can follow. Now for the case 2, it was the patient had an intracranial extension. So it was closer, very, very closer even after post NSCT to the volumes. And that's what I was trying to say. I don't compromise while contouring, but evaluating the plan, I might end up accepting a bit underdose because I have to meet up the priority 1 category. And here we comes to a very important learning point, which is given in ICRO 83, is an overlapping structure and sub-volume. Now you need to create a sub-volume in that while your high doses are overlapping with your serial PRVs, the priority 1 category 1s, and maybe there's a role of adaptive radiotherapy in nasopharynx in that. Now, just a line between sequential and SIB, I have always followed SIB, so I find it quite okay. There are theoretical discussions related to that, even a phase 3 trial. There are no difference between the outcome as expected. Some say SIB has more mucositis, dermatitis. And if you're doing one very important point, if you have to do an adaptive in nasopharynx and you have planned a SIB, ask your physicist to plan full in the second phase also, and then just schedule the remaining fractions. Don't try to ask them to plan for the remaining fractions total dose. Plan as if you have planned 70-33, say at 20 fraction, you're doing a rescan and doing for adaptive replanning. Ask again to plan 17-33, evaluate the plan, schedule for the remaining number of fractions. Now, sometime back in Green Journal, this very nice paper got published in nasopharynx. What will be the adaptive radiotherapy risk profile where you have to do and where you can omit. So very important is heavy nodal burden, higher patient's weight, and initial nodal size if large. You need to train your radiographer. It is very important that they are seeing, most of them, if they're doing an IGRT, they have an image protocol in your department set. So they really need to update that what it is going in patient scan, because there are a lot of data related to where you have to do the rescan for nasopharynx. And it is a bit different compared to other head and neck because it might shrink early. So this nice article got published some time back. And in nasopharynx compared to oropharynx, the median time to do adaptive rescan is around 15 fraction, because in other head neck, we might do it at 4 weeks, 4.5 weeks. So this is important for nasopharynx. And I would suggest, if you're doing and starting this protocol in your organization, try and see the online images as far as possible by yourself. Now, there are data also that does it translate into clinical outcome? It says for higher tumor volumes and the higher T stage. 2-3 very important point in adaptive. I have seen many juniors jump to adaptive and change the volume. So remember, no ICRU has given any separate guideline for adaptive radiotherapy. They did not define any mid-treatment volume. Very important point, do not change the craniocaudal extent of your original GTV and CTV. You just have to edit something going out of the skin and going in the air. Change in the volumes, like I have said, and it should be delineated manually again. Even if you have a very high-end deformable image registration, please go back and see in your rigid registration and manually edit what it should be. But please don't suddenly change the volume, because tumors don't behave that way. Now, salivary gland, because of the paucity of time, Dr. Cecil highlighted very important things. I just have kept a case and highlighted few points. Sorry, Abhishek, I really could not manage salivary after the extensive nasopharynx going into detail. I would urge people definitely to reach the Coaster guideline and the ASCO salivary malignancy article published last year. And this been discussed. So,
Nandan, can I just come in one thing?
Yeah.
Can you try to finish by 5 minutes or so, because we have the questions to discuss,
yes.
and Dr. Costa will be dealing with that part. So if possible,
Sure.
just highlight the salient
Yes.
points in the next 5 minutes. Thank you.
Sure. Thanks. So again, this we have discussed many a times today. Why I'm highlighting, because it looks very nice, but it does not look that great while we can't do. Now, I just highlight a case for the salivary. This was a 55-year-old female diagnosed as adenoid cystic right parotid. We thought to be T3N0 or maybe a T4B. Why? I'll tell you. The patient also had a right B skull deposit in the internal carotid and cochlear area, and where they thought to be a meningioma or schwannoma by neurosurgeon. Eventually, sort of underwent debulking and realized it is actually a deposit from ACC parotid. There were mild facial deformity. We discussed in our MDT. This is a very interesting case. The patient been treated 1.5 years back and still okay. I thought of putting it because it has a lot of contouring challenges. So one might argue this is a metastatic disease. One might argue this is a directly a sort of a perineural spread, which is common in ACC. So we stamped it that way. Eventually, the biopsy also was AR positive and PNI positive. And this is, I could not get the MRI because it was filmed for that patient. This was the pre-planning PET-CT. There was some diffuse uptake in the parotid, very low grade. MR brain still showed some subtle persistent right cochlear region enhancement, query residual. So we thought of covering that also. We decided to try and treat radically this, try to put 70 gray around this parotid and maybe the gross area as far as possible. Follow the COSTAR guidelines, sorry, it spells as COSTAR, and the PNI tracking, and try and give between a 59.4 to 66 gray as comparing and respecting the OAR. And of course, we had to treat the neck because it was not addressed, the ipsilateral neck. So we know about the COSTAR, I'll skip this, and the PNI tracking guideline. For parotid, the 7th nerve remains important. Initially in the radiology lecture, Shaunok highlighted that very, very well. And this is the stylomastoid also he covered. I thought of putting it how you can see it. This is a very important foramen to cover since this patient had perineural spread. And this is the final volume. Now see, if you follow the COSTAR, this extra area where you can see the crosshair, if you can appreciate, should not have come. But this patient had an query cochlear deposit and we had to cover all these area. So we eventually ended up covering all that. And again, respecting the PRV brainstem as much as possible. And this is on the left, the COSTAR, how it looks like cochlear sparing. And this is what we ended up doing because this was eventually a very different case altogether. We had to track all nerve roots and cover them. And this is what I was again try to highlight between the serial OAR and pre-TV. Try and accept bit of underdose. Don't please do under contouring in your evaluation. Then you can see it in better. And this is what I try to mean by that in the color wash. So the take home points would be, one should be consistent, know the guidelines, read the validated contouring guidelines, follow uniform plan evaluation parameters, follow up and document acute and late toxicity. Imaging assessment is very important to see. And finally, tumor coverage supersedes the OAR always until there are very compelling scenarios. And this might come as a future later on nasopharyngeal carcinoma of different other ways of doing contouring and plan evaluation. So thank you.
Thank you, Pranjana, for the excellent presentation.
Thank you.
So I will move to some questions. So first we'll start with the question of Dr. Kannan. I think Dr. Cecil will take the question. Sir, when treating the retropharyngeal node in elective setting, dose of 44 gray will be adequate for the lateral fields in the retropharyngeal group of lymph node? Is it?
So the question is, what should be the dose for the retropharyngeal lymph node selective?
Yeah, basically,
Right.
initially 44 gray will adequately cover the retropharyngeal or not, or will increase or something?
Okay, so for the intermediate risk column, because the as the Dr. Basu clearly mentioned, that retropharyngeal and retrostyloid lymph nodes will be the part of the CTVP2. So whether this should be given as separate volume, usually we do not need, because this will be part of the CTVP2. In that situation, what dose should be given? Even if you go to the international guidelines published in 2018, the doses should be ranges between 50 to 60 gray. So there you cannot clearly say that the 60 should be given or 50 should be given. My personal view should be, if the patient is having a bulky disease, especially posteriorly involved, then prefer to give 60 gray. But if somebody is saying that 50 is good enough, that's also, we cannot clearly say that what he is doing, what he is saying is wrong. So it should be ranges from 50 to 60 gray. I believe that 44 gray is not sufficient.
I mean, in case of the conventional planning, the initial plan should be up to the 44 gray.
Yeah, that is the problem with that is the problem. Yeah, in that situation, in the post-op, we are doing a spinal cord shielding at 44 gray, but the superior part will continue to 54 to 60 gray. So in that situation, that area will cover to that area to receive to 54 to 60 gray in two-dimensional radiotherapy even. We are only shielding spine after 44 gray in two-dimensional radiotherapy planning. You are not shielding the retrostyloid area or retropharyngeal area after 44 gray. That will continue to 54 to 60 gray. My personal view is that if the brainstem can be spared after 27 fractions in 2D planning, you can shield the brainstem, but still that area, if the clivus is not involved, then adequately that will cover that. But if the clivus is involved, then that will be a problem, because you will be forced to get a high dose to the brainstem. You will be forced to accept that.
Okay.
Yes, very true. Very true.
The next question, Dr. Abhay, how much dose should we give via photons in case of mixed beam?
You mean in parotid?
Yeah, no, I guess he's asking in the nasopharynx about the
nasopharynx, the posterior electron boost, right?
Posterior, exactly.
Yeah, posterior electron boost. That's a very good question. If the nodes are involved, that's what personally I suggest is that you have to go by say 66 to 70 gray, because the macroscopic, any involved node, it should receive a 70 gray equivalent dose. That should be the standard, because it's a macroscopic disease. So for that purpose, after the 44 gray, you de-shield that, then the posterior electron boost should get, sorry, I didn't mention that actually. So you should give at least, if the nodes are not involved, then you can limit that to 40, another 6 gray to 16 to 6 gray, because that will be between 50 to 60 gray. But if the nodes are involved, then definitely you should include that area to 66 gray, minimum of 66 gray. So those will be 22 gray after that 40 gray of spine.
Yeah, exactly. Next question by Dr. Nikhila. Should the vocal cord to be included? I think VC she's mentioned in case of the stage 3 or 4 disease of the nasopharynx. I think VC she's asking about the vocal cord, I guess.
No. Kostav, I think level 5C.
Acha, it's a VC is a level 5.
Yeah.
Okay, fine.
So, Dr. Basu, you want to take up that?
So I generally, even to the lowest, if lower neck is involved, undoubtedly, like level 4 is involved, or you have level 5, beyond doubt we have to cover. If it is N plus up to level 2 and other nodes are not involved, I still try to cover the host triangle to a lower dose. Maybe I do SIP, so 54 in 33. There is some data, Sharvani ma'am is doing a trial of doing 45 also for them. But I try to cover them. Maybe not 5C properly, but 5A, 5B for sure.
So, yeah,
Okay,
prophylactically. So
next, yes, sir. Please.
you have to go one level down. If the level
Yes.
2 is involved, then level 3 also sure. So you have to include into the intermediate, the CTV N2. The CTV N3 will be below that. If the patient is in level 2, level 3 will be CTV N2. But you need not take that in other sites. But the international guidelines say that if you have a node in level 2, level 3 also should receive 60 gray.
Yes.
Then the rest should be given, as Dr. Basu said, then that will be given to 50 to 54 gray equivalent dose.
So next question, is there any role of concurrent chemoradiation in the adjuvant setting for a recurrent parotid gland malignancy?
Yeah, that's a very good question. If in a recurrent parotid tumor, the first treatment will be always the patient should have a surgery. Okay, after surgery, whether the question is that whether we should consider post-op chemoradiation. So as of now, we have to understand that the data is not so mature to consider chemotherapy along with radiation, even in recurrent setting or in the upfront setting where there is a margin is positive. Even if you have an extracapsular extension in a node from a parotid in a level 2 region, whether that should be given 66 gray plus chemo, I do not know the answer because there is no data. For that matter, the extracapsular extension region or where there is a margin is positive, I'll try to give a higher dose of radiation. Whether I will add chemotherapy, that's a matter of debate. Because the JAMA paper published in 2016 shows that there is a negative impact if you add chemotherapy, and the phase 3 trial for concurrent chemo along with radiation is underway. So as of now, we have no hardcore data to consider chemotherapy in the adjuvant setting.
So if I can make a comment.
Yeah,
so
sure.
What we do in our center, that yes, we also do maybe try to boost till 66. For the histology wise, for the high grade salivary duct and adeno and squamous, we try to give concurrent, extrapolating otherwise head neck data. It's not evidence based, it's level 7 evidence. But yeah, we try to add for these 3 histologies. But for ACC high grade margin close, no, nothing, just radiation. Vijay Patil had been around, he would have been very happy listening to this.
Okay, I think another last question. What levels to cover from T4N0 nasopharyngeal? I think Dr. Basu has been already told, but again, answer.
So T4N0 would be initially NSCT for sure. Once after your NSCT response evaluation responding, then primary, the node. So the node, what I would do, because T4N0, you have mostly Indian data. Dr. Sharvani has one publication sometime back after the induction. So the primary would cover the level 7. I would also cover level 2 at least to a dose of 60, not 70, and the other levels 3, 4, and elective 5 in 54 equivalent.
Yeah, if you go to the international guidelines in 2018, say that, okay, so you give the CTV N2 for N0 will be the bilateral retropharyngeal, bilateral level 3, bilateral retropharyngeal, bilateral level 2, bilateral level 3, and bilateral level 5A. But what dose should be given in an N0 region, whether it should be a 50 equivalent dose or a 60 equivalent dose, that's a matter of debate. Okay, but for a CTV N2, you should give that earlier. But whether it should be give 50 or 54 or 60, okay, you can decide that. Okay, it's a matter of personal judgment because there is no data on that.
So one last question is there any evidence of the taxane plus platinum in NSCT?
Taxanes plus platinum in NSCT. If you go to the 6 randomized clinical trials, if you look into the trial comparing, there is a trial comparing the chemoradiation versus modified TPF, and there is another trial that is from the another trial comparing the full dose TPF. Full dose TPF was the trial from the GOTA group, and yes, they used the 75, 750, and the 75 docetaxel, cisplatin 75, and the 5-fluorouracil 750. And the Chinese trial used 60 milligram per meter square of cisplatin, 5-fluorouracil 600 milligram per meter square, and docetaxel 60 milligram per meter. That's called the modified TPF. These 2 trials have shown a comparison comparing to concurrent chemoradiation. There is a survival benefit. And The second trial, the GOTA trial, was prematurely closed, but there was a trend towards improvement in overall survival, but there was an improvement in progression-free survival. So there is data comparing 3-drug is having compared to concurrent chemoradiation. But recently there are 2 phase 3 clinical trials, one published in Translational Oncology in 2019 and other published in JAMA Oncology in March 2022. And if you look at the paper published in Translational Oncology 2019, April edition, show in the month of April, comparing the 3 drugs, cisplatin, 5-fluorouracil and docetaxel versus cisplatin and 5-fluorouracil. They published the 3-year results and there is no difference in outcomes. And there is a recent paper complaining the paclitaxel cisplatin, paclitaxel capecitabine data and the cisplatin capecitabine and paclitaxel versus cisplatin 5-fluorouracil. The data published in JAMA, there is no improvement in overall survival, but there is a reduction in distant metastasis. But there is similar toxicity. One trial is positive, one trial is negative. So to conclude, you cannot clearly say that 3-drug is superior to 2-drug in terms of outcomes in nasopharyngeal carcinoma. So if someone is using cisplatin 5-fluorouracil compared with chemoradiation, again there is data showing that is showing survival benefit. To use cisgem compared to, there is a recent update of the cisgem trial very recently in JCU, very recently presented in the ASCO 2022, now they published in JCU in 2022, shows that the benefit is consistent at 5 years, showing cisplatin gem versus concurrent chemoradiation alone. And they also analyze, there's a very good finding that the benefit is more for patients who achieve complete response with those who have a response, there is a long-term outcome. And also those who have low EBV value, low EBV DNA value, the induction chemo has no much benefit. That is the inference from the long-term results of the cisgem induction part.
Okay, thank you, sir. It's an extensive discussion, and thank you for, I mean, your valuable input here. Thank you, Dr. Basu and Dr. Sejal. And good night, to everyone. And we'll look forward for the next class. It's on hypopharynx and the oropharynx. It will be on the next Wednesday from 7:30 p.m. For that note, it concludes today's session. Thank you. Thank you very much.
Thank you.